Good morning, everybody. We start the oral poster presentation. The first speaker will be Dr. Aditya. Dr. Aditya, please.
Good morning, everyone, respected seniors and my colleagues. Myself, Dr. Aditya, and I'll be presenting about different types of cervical spine injuries in our institute with different outcomes within last 1 year. So, the spinal trauma is notably cause of morbidity and mortality among young adults after road and workplace trauma worldwide, and it represents significant portion of musculoskeletal injuries and trauma from the traumatic accidents. Second peak of incidence concerns over 65-year-old people, and living only 1 to 3% of events in people before age of 15. Most commonly affected segment is the caudal part presented by the by C6 and C7, while the third of the cases C2 is affected. We have 7 different types of spinal cord injuries reported in the last 1 year. So first case is skip corpectomy. And this young male, 25 years old male has presented to us with diving into the shallow water pool and had upper limb, bilateral upper limb weakness and lower limb weakness with bowel bladder dysfunction. Bilateral upper limb, lower limb gross power was 3/5. So anterior, with an anterior approach, we did skip corpectomy. Patient had burst fractures of C5 and C7. So we have done the skip corpectomy, and post-operatively patient has improved well, and this year only he got married with retained sexual functions. Then anterior case 2 is anterior fusion alone. This is 60-year-old male patient presented with neck pain, weakness of bilateral upper lower limb and tingling sensation, and history of fall. He has having history of fall while carrying heavy weight over his head. Gross power was upper limb 3/5 and lower limb it was 4/5. All reflexes were brisk. Post-operatively, patient improved well and went home walking. Third case is anterior corpectomy at the single level only. She was a 60-year-old female, had history of giddiness and fall. Initially, initially it was it was suspected as a case of vertebral vesicular insufficiency, but after MRI it was diagnosed that there was a wedge compression fracture of C5 vertebra, C6 vertebra, and after that patient underwent corpectomy. Fourth case is the 360-degree fusion, anterior as well as posterior. This 28-year-old male patient had history of RTA, and after that bilateral upper lower limb weakness was there, and gross power was 2/5 in the upper limb, and lower limb was 1/5. Post-operatively, patient was improving, but unfortunately, patient succumbed to aspiration pneumonia. Case 5 is the corpectomy and discectomy. Patient, 24-year-old male patient with skid and fall from two-wheeler, upper lower limb power 2/5. Patient has survived, post-operatively, patient has survived and has improved in upper limb function, but left with paraplegia. Case 6 is the C2 odontoid fracture. He was a 22-year-old male patient with history of skid and fall from the bike. And patient complained of only neck pain, but there were no deficits. So we did posterior C1, C2 fixation.
Take-home message.
Yeah. Take-home message: cervical spine injuries. They are prompt diagnosis and early treatment is will give you the better prognosis. Understanding the biomechanics of the cervical spine is very important, and treating such injuries and decompression and stabilization is the basis of treatment. And challenges are the risk of GA, complexity of the surgery, prolonged hospital stay, rehabilitation, and physiotherapy, as well as financial and mental problems and dependency of the patient as well as of the family. Other challenges like UTI and pressure, so they have to be managed continuously during the further life. Thank you.
What is the most common cause of deterioration in elderly patients when you do a corpectomy and fixation?
What, sir? Can you please?
Most common cause of post-op deterioration in elderly patient when you do a corpectomy and fixation in such cases?
Burst compression fracture only when there is anterior columnar disruption along with.
Doctor, with the different variety of injury,
Yes,
the
sir.
outcome will be different.
Yes, sir.
One is the sublux, there will be 3-column injury.
Yes, sir.
Some of them are type 2B injuries.
Yes, sir.
Obviously different injuries. Is it you are trying to compare a similar kind of injury with a different surgical outcome, or different surgeries
No,
overall you're presenting?
overall present. I am presenting
You are
different
present
surgeries.
one.
Yes, sir. Yes.
Okay, thank you.
Yeah, thank you, sir.
The next we'll call upon Dr. Bharat Raju, who will be talking on optimizing sacral screw technique for complex sacral paradox.
Very good morning, everybody. I'm Dr. Bharat, resident neurosurgery KMC Manipal. So I'll be talking about optimizing sacral screw techniques for complex sacral paradox. So introduction, the first instrumented fusion technique was actually of the lumbosacral spine, which was developed by Harrington. And then kept the Galveston technique, which improved the ability for long constructs. And also major advances was that they did incorporation of the ilium. So iliac screw fixation has actually a low pseudoarthrosis rate and a high fusion rate. Iliac screws are typically directed towards the PSIS, from the PSIS to the anterior inferior iliac spine and anterior superior iliac spine as well. The iliac fixations act as an adjuvant for the lumbosacral fixations, and here we actually report use of a novel freehand technique for the iliac screw placement based on the landmarks and modification of the standard trajectory for a complex pathology. Coming to case details here, a 51-year-old came with a known case of CKD with an obstructive uropathy, had come with low backache. Here they had he had left hip, knee and ankle weakness with bilateral EHL weakness. Got an MRI done, showed a lobulated mass lesion in the sacrum involving S1 to S3 and also the bilateral sacral ala and left sacral iliac joint as well. Here partial sacrectomy was done, bilateral L4-5 pedicle screws, right S2 to AIIS and left modified PSIS subcrest screw was done. Here discussion part, since there is a high fusion rate and low pseudoarthrosis rate, which is the desired goal, two trajectories are there for the availability of the iliac screws. One is towards the superior rim of the establishment, other to the AIIS starting points. Here we proposed a new trajectory towards the midpoint of the iliac crest rim with an entry 2 mm below the standard PSIS entry point. Here the yellow indicates the trajectory of the proposed trajectory and the red indicates the previous two normal trajectories which we generally use. So here freehand technique placements of the iliac crest is both easy to perform and safe for the patient. Posterior superior iliac spine is relatively constant across all populations, but further study is needed for the same. It's an easy learning curve and can be used in various sacral pathologies where more lytic lesions are there and acts as a reinforcement for a normal lumbosacral fixations as well. Subcrest iliac screw fixation is easy, feasible, safe and potential to reduce screw head complications since the entry point is at a lower level. For this, yes, further study and validation is needed for this technique to be warranted.
Two things I want to know. One is rod contouring and its position with respect to the paraspinal muscle, rod contouring. Because you're doing at the mid, iliac crest level, right? The posterior PSIS to ASIS, the rod can be contoured beautifully in the U shape or you can do it in the L shape. The contouring will be difficult and it will come closer to the surface when you do this procedure.
So
Contouring of the rod, because
yes,
you fix at L4, you fix at L3, then at the iliac region, right?
You can use a connector, sir, in between. So that
Connector you will use it. Okay, so that will reduce the principle of the stabilization or it doesn't reduce?
no, it doesn't reduce.
Is there a fusion rate you have checked?
Yes,
How
sir.
many
For
cases
this,
done? Only one
no,
case.
We did only the one
Okay.
case, so it needs
Fair.
to be warranted.
Okay, thank you. Too sure.
Sheikh Gautam. Yes. I think he'll be presenting on unveiling the uncommon xanthogranulomatous osteomyelitis of the occipito-atlanto-axial region. Yes, Gautam.
Good morning, everyone. I'll be presenting on xanthogranulomatous osteomyelitis of Atlanto-occipital joint. Xanthogranulomatous osteomyelitis is a rare chronic osteomyelitis characterized by foamy macrophages and mononuclear cells. Cervical exo has been reported only once in existing literature by Pereira et al., and to date there have been no reported cases of exo at Atlanto-occipital region. A 54-year-old male presented with 2-month history of progressive neck pain, stiffness, occipital headaches, and low-grade fever peaking in the evenings. He was a known case of hypertension with uncontrolled diabetes. On clinical examination, revealed pain from the upper cervical to occipital region with limited neck movements and stiffness, while neurological function remained intact and Kernick sign was negative. MRI cervical spine showed heterogeneous lesion appearing hyperintense on T2, involving the anterior arch and lateral mass of the atlas extending to the right occipital condyle with thickening of the prevertebral fascia. The lesion shows post-contrast enhancement, and CT cervical spine showed an ill-defined lytic lesion with erosive changes involving the anterior arch and lateral mass of the atlas on the right side extending to the right occipital condyle. Patient underwent a transnasal supra- and infraparietal approach with both endoscopic and microscopic techniques. A bulging mass was noted of 1 centimeter from the midline on the posterior pharyngeal wall, which was incised and revealing a thick yellowish pus and granulation tissue. A ring curettage of the Atlanto-occipital joint was performed with avoidance of instrumentation due to ongoing infection. Intraoperative image showing a ring curettage at the Atlanto-occipital joint. The biopsy tissue was sent for histopathologic examination, revealing necrotic, bony spicules, mixed inflammatory infiltrate, and granular tissue, along with fibroclinogenous background. Gram staining showed pus cells. Both GeneXpert and AFB tests were negative, and pus culture and sensitivity revealed methicillin-resistant Staph aureus, which was sensitive to vancomycin and cefotaxime. Cervical exo has unusual locations like Atlanto-occipital region. Early recognition and accurate diagnosis. Thank you.
Thank you. Have any questions? No.
Sir, because of uncontrolled diabetes could be a precipitating factor, and as per literature, pathogenesis includes type 4 hypersensitivity reaction in cell-mediated hypersensitivity, sir.
Now, you said the early recognition. Do you have any characters to look for the early recognition? Because many a times, any infection you see at Atlanto-occipital, first thing we think of is tuberculosis.
Yes, sir. Our primary diagnosis was
categorize xanthochroma. Do you have any particular characters?
No, sir. Initially, everybody thought it was tuberculosis only. This is a pathological diagnosis, sir.
So only after the
after pathology, sir. Yes, sir. Thank you, sir.
Next speaker is title clinical and radiological outcome of spinal and regional bone cyst and institutional experience by Dr. Nilesh Chaudhary. Nilesh Chaudhary is there. Next speaker will be 2-level IDEM embracing dural perspectives. Dr. B.V. Sandeep.
Intradural extramedullary tumors of the spine are uncommon neoplasms comprising 0.3 to 0.5 per 1 lakh and account for 1/3 of spine tumors. This case study about the management of a 34-year-old male who presented with a 10-day history of bilateral lower limb weakness. Imaging revealed IDEM at 2 levels, at D5 measuring 32 mm and at D11 measuring 22 mm. Aim is to report a rare case of 2-level IDM at D5 and D levels in our institute, Ballari Medical College and Research Center. Materials and methods. A 34-year-old male presented to neurosurgery emergency department at BMCRC with complaints of bilateral lower limb weakness and urinary incontinence, and was diagnosed on MRI to have a D5 and D level IDM. Prompt microsurgical intervention was conducted and complete total excision of both tumors were done. Intraoperative images are depicted as well. And coming to results and discussion, post-operatively patient demonstrated a favorable post-operative recovery with no residual neurological deficits. IDEMs, despite their slow growth, can lead to significant morbidity such as pain, motor deficits, sensory impairment, and urinary or fecal dysfunction. Therefore, early diagnosis and microsurgical resection are crucial for optimal outcomes. This approach is well supported by documented safety and efficacy in achieving complete tumor removal and minimizing neurological sequelae. This HPE was reported as schwannoma by the pathologist. And coming to conclusion, IDM are a rare entity and their management is challenging. The successful management of a rare case of 2-level IDM demonstrates the effectiveness of our surgical approach in addressing complex spinal conditions. The patient's favorable recovery trajectory underscores the potential for positive outcome when employing meticulous surgical strategy. So here we presented a rare case of 2-level IDM in one patient. Sir.
Thank you. Nice one. Sir, see, this is not uncommon.
Sir.
Number one. Number two, see, in these patients where you see multiple IDMs, majority of the time they are associated with NF2.
Yes. So this patient had no
NF2.
Nice.
And in these patients, before you take them for surgery, you must have a brain scan.
Sir.
Because they may have multiple neurofibromatosis, meningiomas, gliomas, and other things.
Yes, sir, we had done, sir. No,
You
nothing
had
was
done,
done.
but you're not shown that.
Sir.
So this is very important. And they're not very uncommon. You see them quite often, right?
Okay. Thank you.
Next is Dr. Nilesh Chaudhary. Title, Clinical and Radiological Outcome of Spinal Aneurysmal Bone Cyst and Institutional Experience. Is there? He's not there? Okay. Then Nagcharan Gowda, Respiratory Distress and Quadripresses in Pediatric AEDs, secondary to Odontoid.
Good morning. I'll be talking about a case of respiratory distress and quadripresses in a pediatric AED secondary to all odontoidium. So we have a case of 7-year-old male with complaints of weakness in all 4 limbs since 2 months with breathing difficulties, pain in right upper limb and both lower limbs, difficulty in standing and walking with decreased oral intake, occasional urinary incontinence with no bowel involvement. On examination, the patient was emaciated and malnourished. He was tachycardic, respiratory rate was 24. He had a paradoxical breathing pattern, weak cough, single breath count of 2, and he was in respiratory acidosis. His CNS examination revealed hypotonia in all 4 limbs. Power was 1/5 in all 4 limbs. Deep tendon reflex were exaggerated. Bilateral plantar reflex were extensor, and GAC reflex was weak. So the preoperative plain X-ray shows atlanto-axial instability with what appears to be a dystopic os odontoidium. So T1 weighted sagittal images showed severe compression at the cervico-medullary junction with cord changes, which is confirmed again at T2 images. And just to rule out any malignancies, we got a contrast MRI. This is the T2 weighted axial images showing cord compression with cord changes. So the dilemma we faced was whether to operate the patient considering his respiratory status. So we talked to the patient's family about the possibility of a tracheostomy and long time ICU stay post-surgery and the poor outcomes of the surgery. And once with consent, we went ahead with the surgery. So under neuromonitoring, we did a OM navigated C1, C2 fixation. This is the post-op image. The post-op CT we got done, which shows the C1 and the C2 screws, the reduction of the dens. At C1 level, we did bilateral screw fixation in the lateral mass. And at C2 level, right side, we did a lateral mass, and the left side, we did a laminar screw fixation. We are on telephonic follow-up with the patient. And right now, he's walking around by himself. He's yet to come for a 9-month follow-up. Thank you.
Odontoidium caused the problem, or is it related to instability in the joint which created a problem?
So the history was he had a fall, following which he started showing weakness. Sir. Before that, he was completely normal.
So it's related to Atlanto-axial dislocation?
Yes, sir.
Okay.
Dr. Vikrant.
Good morning, everyone. My topic is multiple symptomatic spinal intradural arachnoid cyst. It is a case report. Usually, spinal arachnoid cysts are very frequent in thoracic region, and multiple cysts are very rare entity. If they are present, then they have been reported in females in the second decade, and especially intradural cysts are very rare, and especially in multiples. But this is a case report. It was a 9-year-old child with progressive bilateral lower limb weakness and incontinence. The examination findings were bilateral lower limb weakness, and there was a decreased anal tone, and the DTRs are decreased in the ankle jerks, and the plantars are bilaterally extensor. So it was on NCCT, which was done outside. They had diagnosed epidermoid cyst from L5 to S4. But when we did the MRI, there were possibility of there was a discussion between radiologists and neurosurgery people that it is a single cyst, intradural cyst. But with better visualization, we find that there were 2 cysts. And because the intradural cysts, they have no clear demarcation between the dura and the cyst margin. For extradural cysts, which are more common, there is a clear demarcation. Moreover, in the intradural cyst, if they are multiple, there should be a clear demarcation, as we are seeing in this image, in the lower 2 images. So it was intradural cyst, 2 intradural cysts, T12 to L5 S1 level, and second one was from S1 to S4 level. So we did the surgery, L1 laminoplasty, which is now the procedure of choice for this kind of lesions, and the surgical excision of the cyst we did. Of course, there are some parts which are adherent to the phylum and the roots, which were just marsupialized and coagulated. And in the post-op recovery, we find that by post-op day 3, patient started walking, and he completely regained the sphincter function. After 2 months of OPD follow-up, full functionality, intradural and multiples. It is rare, and initially it may be often misdiagnosed as dermoid or epidermoid is in our case. And even in MRI, one can miss that it is multiple or single. And so the early diagnosis and adequate intradural surgery is the key to regain complete function.
Doctor,
Yes, sir.
first of all, radiological diagnosis is wrong.
Yes.
Second, how do you differentiate this from Tarlow's cyst?
Sir, initial diagnosis, because clinically we find that there was sphincter dysfunction and bilateral lower limb weakness with some of the myeloradiculopathy features. So it did not localize completely to the sacral region. Yes, sir.
So most of these patients, if you put a dye and put it, it'll usually start leaking from the root where it is coming. And
Yes,
opening from L1 to L5 is not required in this patient. You had to plug that area, otherwise it will recur within 3 months to 6 months in most of these patients.
Yes, sir,
related
but,
to spinal
yes,
hypertension, it happens.
Yes, sir. Sir, actually in literature it is reported that the main problem in such patients is intracystic connection, which has to be found, and also the connection with the dural opening. So, yes, sir, intracystic connection we found, and we coagulated it.
You plugged it?
Not plugged, sir, coagulated.
You have to plug it.
Yes, sir.
Don't plug it in recur.
Yes, sir. Thank you, sir.
Somebody else is there?
On behalf of our co-chair, we thank and congratulate all the speakers for their excellent presentation, and thank the audience for excellent interaction. Thank you. We'll conclude this session of the...
Thank you, judges. again, my favorite part of the day. I would request only the groups, the groups for the workshop have been divided, so I would request only those from in the 9 to 11 group to go to the 6th floor, and not everybody. You should have a list on WhatsApp regarding which group you guys are in. We will be starting the How I Do It sessions. I'd like to remind everybody that this is a Sunday and nothing happens after today, which means we really need to stick to time because this cannot go on all day. And in addition, there will be some changes based on when our esteemed faculty's flights are. So the order is not going to be exactly how it is listed. So without any further delay, Dr. Dugani sir. We have a straggler. We have Dr. Benak giving his presentation.
Please tell your name and your topic. Hello.
Good morning, sir. My name is Dr. Benak from KMC Manipal, and I apologize for the confusion and inconvenience. Okay. So, it's almost an established fact that certain spinal deformities are common in NF1, like spinal dyslectasias, spinal skeletal deformities. Now, I'm presenting a rare case of a chaotic conus lipoma in an NF1 kid. So, this is a 4-year-old child, male child, who presented with urinary complaints and limb length discrepancies. At birth, he was found to have a sacral subcutaneous swelling, and an ultrasound showed a spinal lipoma. Examination revealed for 14 Kefalow spots. There was a limb length discrepancy, but there were no motor deficits. Then on imaging, you could see a fat intensity signal lesion at the tip of the cord in the conus region, which was tethering the conus to the subcutaneous tissue. And it was kind of infiltrating the conus without a clear plane between the placode and the lipoma. Now, the baby underwent excision of the detethering, basically, from the lipoma and the fatty phylum, which was connecting the conus to the subcutaneous tissue, and partial decompression of the lipoma was done under neuromonitoring. EMG and nerve stimulation was used. And as you can see in the photograph, there was no clear plane between the neural and the lipomatous tissue, and most of the nerve roots were admixed within the substance of the lipoma. So there is a relatively sparse literature which is available on NF1 and tethered cord syndrome. Now there are extensive literature review was done, and there were just 3 studies. One was Yang et al. And Bajang et al. They said that the most tethered cord syndrome is more common in NF1 patients compared to the general population. But there is no literature regarding spinal lipoma, tethering of cord, and NF1. So this makes the case a little unique. And this case highlights the importance of getting a screening MRI for patients with NF1 to look for tethering of cord and spinal lipoma, and especially in cases with spinal deformities, because correction in that setting, it can be a little detrimental. So it was, we first, under neuromonitoring, sir, nerve stimulation, we detethered the phylum and that lipoma, sir, which was connecting the subcutaneous tissue to the conus. Then when we could not differentiate the plane between the lipoma and the neural tissue, we stopped there, and we got a good fold of arachnoid, sir. We could do a second interrelation to prevent detethering, sir.
Right. That's what, see, in lipomas, I mean, our experience-wise, the literature showed never try to excise them completely. you will cause devastating neurological deficits in these children in the younger age group, and the outcome is very bad. Only try to reduce the bulk of the lesion. This is one case where IONM is mandatory. Without that, you cannot do these cases. What would you like to advise the child or person with the lipoma for future of his life? It's an off the book, many literature manifest. Ask him not to put on the weight.
Yes, sir.
As the body weight increases, the size of the lipoma in the canal keep increasing and causing mass effect. This is the reported one. So better advise him not to increase his weight.
Yes, sir.
As the adipose tissue grows anywhere in the body, it grows up in the spinal canal also.
Yes, sir.
That's the report.
Yes, sir. Thank you, sir.
Do you mean to say NF1 will have a tethered cord syndrome, or is it very common in that and you have to investigate?
Sorry, sir?
Do you mean to say this is an anecdotal case of tethered cord with NF1, or is NF1 produces tethered cord?
Sir, NF1, there's an association, increased incidence. The various studies have shown an increased incidence. But there is no, but spinal lipoma and tethered cord, this is the first case, sir.
Okay, thank you.
Yes, sir.
I'll just. Dr. Nilesh, is he available? Okay.
If nothing is there, we will conclude this session. Don't call us back. Savitar, we are not coming back.
Everybody in the 9 to 11 batch for UBE, nobody is there, I don't know where they are. Please, if you are here, you're not supposed to be here. Please go to the OT on the 6th floor. Is he in that batch? Everything makes sense. First speaker is Dr. Dugani.
Good morning, everybody. Yeah, enable the contents. Yeah, okay. In this morning session, how I do it predominantly, only the confining to the surgical aspects, practical aspects. This is a common problem. As neurosurgeons, we are called upon to treat in our day-to-day work. That's posterior stabilization of C1 and C2, how we do it. Hello? 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 This thing is coming in the way. I can't see the screen. This one. Yes. I'll share with you a case, a small boy, 13-year-old boy, presented with sudden loss of power in both the lower, all four limbs after trivial fall. Examination showed after 4 days, spastic quadriparesis grade 3/5, and he was confined to the wheelchair with the bladder bowel dysfunction. He had, when a skeletal examination was done, general physical examination showed ventricular septal defect, which had closed, and he has congenital vertical talus Rosher bottom foot, bilateral CTEV, pectus excavatum. Otherwise, his physical and mental milestones were unremarkable. He was investigated with the MRI, plain scan, whole spine screening, CT scan, cervical spine, and CV junction, and CT angio of the CV junction. Showed os odontoidium, atlanto-axial dislocation, asymmetry of both lateral atlanto-axial joints, suggesting lateral dislocation, significant cervicomedullary compression with the thinning of the cervical spinal cord. He was put in a traction preoperatively for 3 days, Gardner-Wells traction. It's not moving. Okay. Go back. Slides, we missed the slides. Can we go back a little? After this, we have slides. No, slides were there.
Just a minute, I'll read it. This one?
Before this, we have slides. Imaging.
That's not there.
Go back, escape. Go back, escape. Sorry for the... Okay, they're not there. Okay, doesn't matter. Okay. This is a procedure. All stabilizations we do under cervical traction in neutral position and maybe slight extension, but not in a flexion. Midline incision, subocciput to C4 is exposed, and C1 arch and C2 are exposed to the complete lateral limits. We prefer to do these procedures under microscope with high illumination and magnification. The most important point here is to expose the lateral atlantoaxial joint, and to reach that, the landmark we feel is C2 narrow root. We prefer to sacrifice the C2 narrow roots to avoid the postoperative irritability, the screw touching the nerve and causing the neuralgic pains. Now, once that is exposed, we decompress the C1 arch and keep the bone fragments protected and expose the CV junction. At C1, all of us, many who do it know that there is a thick fibrous band which constricts the dura mater at that juncture, and that needs to be excised completely. Now, the point of entry is very important here. We select the midline, midpoint of the lower facet of C1, and a 1 millimeter drill is made in the superior and medial angle, about 15 to 20 degrees. With the tap, it is increased. Then subsequently, screw is put. Next, at C2, we prefer laminar screw in C2. Even you can put the parser screw also. In the midline, midpoint, the tap is drilled and tap is made, and screw is inserted about 1.6 or 1.8 depending on the scan and the child's age and the build and what you see on the CT scan. Similar procedure is carried on to the opposite side, and that's a C2 root ganglion, and usually that guides us to the Atlanto-occipital joint space. Opening the joint space is of utmost importance here, and expose the joint space, and you can see that this joint space is asymmetric compared to the other side, and that was the lateral cause of his lateral dislocation. The cartilage of the joint space is scraped, and the drill, 1 millimeter drill, we drill the joint, again superior and middle. All these things are done under fluoroscopic control, and screw is inserted, and we keep checking it at every stage under fluoroscopy, that due to this asymmetry and the dislocations, tracking the screw to the desired destination is of utmost importance. For that, the intraop imaging is invaluable. Similar procedure at C2, midpoint, pedicle screw,
this goes anteriorly and maybe 10 degrees medially into the body of C2. The screw is placed. Next, we need to fill both the joints, what we have scraped through in the first stage, with the bone fragments, or we can put a spacer with the bone fragments, but we prefer to put the bone fragments. Cartilage is scraped. You can see the joint there, exposed quite well. When the patient is under traction, it's always helpful to distract the joints so that comfortably you can expose them and put the grafts in both the joints. The C1 arch which was taken is made multiple fragments and they can use as a graft. If the bone is less, we can take C2 spinous process, quite big. That also can be used as shown here to put it a graft, to take the soft tissues, attachments from the spinous process and take the bone fragments and harvest them and fuse it with the bone fragments. On both sides, the same procedure is done. That's on what we are doing it on the right side. Now, similar procedure is on the left side. The cartilage of upper joint and lower surface are scraped, and the joint is made raw and put a big fragments. Fill them completely, go as much anterior as possible. Once that is done, the measured rod, completely fill it up, and if you wish, you can put a now longer rod, maybe about 1 millimeter, 1.5 millimeters up and down. Because of the mobility, the rod should not slip and come out. So leave about 1 millimeter approximately and stabilize the rod. When you are tightening the screw, the rod head should hold it, and screw should not move when you are tightening. This is very important because the bone is so small. If the movements are not very smooth, it may damage the bone where you put the screws. So stabilizing that is very important. Hold it and stabilize the screws and tighten the screws without the screws being mobilized. That is where, this is the last step is very important to stabilize the screw heads when you tighten. This is the picture you get at the end of the surgery, where many times younger generation will feel that screws are not parallel to each other. They need not be parallel to each other. As long as they are in the proper place and proper bone, because there is always a dislocation and other things. So don't try to do that. He's put on traction for 48 hours post-operatively. Then he's mobilized with the Philadelphia collar. His weakness improved and completely recovered. Thank you.
Thank you, sir.
Thank you. And this is a post-operative scan, CT, complete stabilized. He's gone back in school after about 2 weeks of his holidays. Thank you.
Thank you, sir. Gani? In the interest of time, we'll just proceed. These are just sessions on how they do it. Can I have Dr. Vikrant here, please?
One question to him, whether the rod should have been contoured or you put the straight rods?
If there is a difficulty in putting the rod, then you need to contour it. If simply and smoothly they can be placed, you no need to contour the rods. If there is a difficulty, see, most important issue here is don't try to move the C1 and C2. You move the rod, but not the bones. So the rod, if it is not fitting well, then contour it. If it is straight where you put it, goes inside, no need to.
Dr. Vikrant Pujari from Rajkot, Odontoid screw fixation.
Good morning, my dear friends, seniors, and colleagues. I am Dr. Vikrant Pujari, Senior Consultant Neurosurgeon, Gokul Hospital, Rajkot. Here today I am presenting odontoid screw fixation, a single screw technique. Incidence of odontoid screw fracture, as you know, is 10 to 15% of total cervical spine injuries. Anatomy, I am not going in details. Various ligaments are important. Aptotic transverse ligament is very important. Integrity of this ligament is very important for this procedure. Types of odontoid fractures, various classification are there, NSSA classification, type 1, 2, and 3, as you know. These are the CT images showing type 1, 2, and 3 fractures are there. Subtypes, as all you know, type 2A, type 2B, and type 2C. Management of odontoid fractures usually are the reduction and hollow west immobilization, reduction and anterior screw fixation, which is the only modality which can provide immediate stabilization. If not able to reduce the fracture, then odontoid excision and posterior C1, C2 fixation or anterior fixation by Parker's technique can be done. There are anterior and posterior surgeries. Advantages, disadvantages are there. Advantage of anterior surgery is the immediate direct fixation of the fractures, preserves normal mobility of the C1, C2, high rate of fusion is there, and immediate improvement in the cervical pain is there. Larson et al. Quoted risk of failure of hollow immobilization is 21 times higher than the surgery in patient greater than 50 years. 1 screw versus 2 screws, Jenkins et al. Alfer is quoted single screw provides much stability and there is much no difference in this 1 or 2 screws and technically is more easier. Indication, as you know, odontoid type 2 fractures, type 2A displaced fractures of odontoid, if undisplaced, can be conservatively managed. Type 2B, anterior superior to posterior inferior fracture must be treated with anterior single screw fixation. Type 2C, anterior inferior to posterior superior fracture can be treated with single screw, provided you can apply pressure with a small needle from mouth. Anterior lateral mass fixation or posterior C1, C2 fixation also can be done. Fracture must be less than 3 months of old. Contraindication, torn tarsus ligament, fracture greater than 3 months of old, and few other. Here we are reviewing a case, 50 years male, history of fall from bike, severe neck pain, giddiness, clinically power grade 4 by pain, or upper limb, lower limb sensations, and all. CT images showing type 2B fracture, anterior superior to posterior inferior fracture, you can see. Anterior single screw technique, simple instruments needed, skin knife, right angle retractor, micro drill system, carries in rounds, all long marked cava, cannula with serration, cannulated type of 4 mm diameter, cannulated lac screw 4.5 mm diameter, cannulated screwdriver, automated drill system. Surgical procedure will go through few steps, induce the patient, supine position with bolster on the shoulder with minimal traction of the neck, apply curve fit wrong retractor, start with 2 kg of increased gravity to reduce the fracture, mark the skin incision transversal. You put a K wire directing from the base of the C2 body towards the tip of odontoid. The wire where it touches the skin usually is the level of the skin, usually at C4, C5, C5, C6 level. Here's the over, which is showing the position of the patient with curve fit wrong retractor, minimal extension of the ink, lower image showing this skin incision level marking. Take small incisions, dissect platysma, identify sternocleidomastoid, dissect separating trachea and esophagus medially, carotid bundle lateral to reach prevertebral fascia. Identify the longest colli muscle. You have to identify the longest. Why it is important? Because you should be strictly in the midline. Marking of the midline is very important. Drill some part of the C3 vertebral body, upper border of C3 vertebral, make a notch. We'll come forward how it is important. And remove some part of C2 3. Place a tip of serrated cannula at the base of C2 notch in the midline, confirm with the C-arm. Drill the K-wire through the serrated cannula so it crosses the fracture line of the odontoid. Then pass a cannulated tap of 4 mm over the K-wire and tap it till crosses the fracture line. Hold the K-wire with artery forceps, should not come out through the and remove the tap gradually. Confirm the K-wire position with the C-arm. Measure the length of the K-wire and select the appropriate of the last size of the lac screw. Pass 4.5 mm cannulated rack screw over the K-wire and tighten till the lac part of the screw crosses the fracture line, and the head of the screw must sit in the disc space under the C2 vertebral body. Confirm the position with the C-arm. Sometimes if the screw causes the distraction, you can put a sponge holder in the mouth with a gauze piece and reduce the fracture fragment. With a CT3 construction, which is showing, here I will go through the small video of this. Marking of the skin incision, usually you have to put a K-wire from the base of C2 toward the tip of odontoid and mark the skin incision usually at 4, 5, 6 level. Take the scene, identify platysma, dissect it, identify sternocleidomastoid as routine steps, dissect trachea, esophagus, medially, carotid bundle laterally to reach the prevertebral fascia with the blunt dissection. And here you have to identify the longest colli muscles, drill the upper top the part of the C3 vertebral bodies, remove some part of the disc. It should be strictly in the midline. The main theme of this procedure, you have to be in midline, and the direction of your serrated cannula, tip of the serrated cannula should be towards the tip of the odontoid process. Once the serrated tip of the cannula is in the notch, you just confirm with the C-arm whether it's directing towards the tip of odontoid process and should be in the midline. Then pass a K-wire through the serrated cannula and drill it with the automated drill towards the tip of odontoid, and it should cross the fracture line, confirm with the C-arm images as shown here. Sometimes this may get distracted. You can apply some pressure on the posterior pharyngeal wall. So here it is reaching up to the tip of odontoid. Sometimes this K-wire may avulse the vertebral body, C2 vertebral cortical surface, and that's a problem sometimes. So you have to be, the notch has to be quite deep enough so the direction and there should not be a thin cortical surface. Then measure the length of the K-wire to select the appropriate size of the lag screw. I'll just run through. Then introduce a 4 mm tap over the K-wire and drill across through the fracture line till it crosses the fracture line. And you have to catch the K-wire distally. That's very important. Otherwise, sometimes the K-wire comes through it. And that's the problem. Sometimes it gets break at the disc proximal end. So holding the K-wire is very important. And now remove the tap slowly. At this time, you have to catch the K-wire. That's very important. And if you see, the left hand of the surgeon has to be very stout. It should not move any direction at any moment of the time. It has to be in a position. And the angle of the direction of your serrated cannula has to be exactly in the midline toward the tip of odontoid process. Otherwise, whole procedures can go wrong. So after removing the tap, select the appropriate size of the lag screw and load it through the K-wire and tighten it. So lower in is the lag screw. You tighten it till the lag part of the screw crosses the fracture line, because this is a dynamic. The lag part of the screw, which is threaded one, which actually distracts the fracture fragment. It just put the telescopic action on the fracture fragment. So post-operative, mobilize the patient on the same day with Philadelphia collar. Advantages are preserves the rotatory motion of the cervical spine. Immediate stabilization is there. Fusion rate is 93%. Complication, as you know, if you're not in a midline, you can injure neurovascular structures. Screws can break down, avulsion of the cortical surface, and some few other. This is the patient with the immediate post-operative second day, and he's almost clinically well preserved, power 5x5, sensations are well preserved, and he's doing well. Conclusion, anterior screw fixation is a treatment of choice for acute type 2 odontoid fractures with no morbidity, immediate mobility, and relief from cervical pain. A single screw is sufficient to provide fixation and fusion. Thank you very much. Behalf of Rajkot Neurosurgeon Association, I would like to invite you, all of you, for our upcoming Nisicon Rajkot 2025, which will be organized on 28th February, 1st and 2nd March. We all welcome you and be a part of this great academic feast. Thank you very much.
Dr. Vikrant, one thing is whether recommendations for 2 screw or 1 screw, that is one. Second part is approach through C3, level of C3 is ideal, or you approach from C5 level which is ideal.
So see, that's what I'm saying. You have to identify first the angle of the odontoid in this patient and position of the patient, how much the fracture fragment has been reduced. That's very important. So initially you apply 2 kg of weight gradually and you see whether it is aligned or not. And the angle of the K-wire is very important. If this angle goes wrong, everything goes wrong. So that is very important. So making a notch on the upper border of C3 vertebral body. That's very confirmed.
That you open, but what I'm saying, approach or entering is always preferable if you go from C5 level and the
lower one will be better. Yeah. Yeah, please.
Especially when the patient's neck is short.
Yes.
And the patient is bulky.
Yeah.
We would prefer the oblique incision
Yeah.
along the anterior border of the sternomastoid, starting below the angle of the mandible, coming down, because the bulky chest and the
Yes.
short neck always comes in your way
Yeah.
of putting the guide wire
Yes.
and the screw
Yeah.
in the inferior aspect of the C2 vertebral body.
Yes.
So when you make a horizontal incision, upper level, your struggle becomes too much.
Yes.
You cannot enter. There you may cause damage to the esophagus and
Yes.
struggling.
That's true. We follow the same thing in a very short neck of the patients. Yes, we do follow.
Go down.
Yeah.
Expose wide.
Yeah.
Then you can access it very well.
Yeah.
That's what answers his question.
No, no, it has to be minimal extension. That should not be exactly a significant extension. It has to be a minimal extension.
Thank you. Thank you.
Thank you, Dr. Vikrant.
Thank you.
We next have Dr. Arvind Patija speaking on minimally invasive C1, C2 fixation.
Kindly keep to the time.
A very good morning. At the outset, I'd like to offer my gratitude to Dr. Shastri and Dr. Manas for inviting me here. I'll be presenting very quickly on MIS C1, C2 fixation. In our institution, we've just started doing this about a year ago. We've done about 4 cases, and this is an early part of our journey in trying to achieve minimally invasive C1, C2 fixation. So we need rigid head fixation, preferably with neuromonitoring, and after the neuromonitoring is established baseline, then we try to reduce the C1, C2 dislocation. And O-arm and navigation guidance is crucial to this procedure. We use expandable retractors in a muscle splitting incision, microscope of course, and navigable, which is the button for this? This one? The navigable drill is a very crucial part of the armamentarium because it enables us to drill the pilot holes without applying too much pressure on the spine, because that can alter the navigation accuracy. So the steps are neuromonitoring setup with baseline recording, prone position in the collar after the baseline is established, head and head pins under reduction, patient reference frame. We use the cranial reference frame and then acquire the O-arm images. Then skin marking is done under navigation guidance again to make sure that we are exactly over the C1 and C2 screw entry points and over the joint. We make paramedian skin incisions, usually under magnification, dissect the muscles along the length of the fibers, and then identify the vertebral arteries with intraoperative microdoppler, sectioning of the C1, C2 roots, exposing the joints, drilling of the screw holes, joint preparation, bone grafting, then insertion of screws, placing the rods, and then finally skin closure. So this is how the patient is positioned. As you can see, the cranial frame is used here on the head fixation device over here. This is just a brief overview of the posterior cervical spine muscles, just to show the direction in which we dissect the fibers. This is an image of the right C1, C2 joint. So this is the cranial, this is medial, this is the joint, this is the Doppler probe on the vertebral artery. The video, excuse me, can play the video please? So we try to correlate the navigation and the microscope images here. So this is the exposure of the C1, C2 joint. At every step, we make sure that we are following the navigation. This is the drilling of the screw holes using the navigable drill. As you can see, we get a very clear image of exactly where we are going. Once we have achieved the required length and trajectory, then through the navigation system itself, we can measure the diameter and the length of the screw that's required. Also here, it is much easier to get proper bicortical purchase if one wishes to do that. This is a video of the facet joint preparation. I'll skip that. This is drilling the end plates of the C1, C2 joints. Bone graft, we usually prefer to use allograft in most of these cases because we're not really harvesting any of the native bone. Use of a spacer is also optional at this stage. In this particular case, we didn't need to use a spacer so much because we got good reduction. And this is the insertion of the screws. I generally use the same retractors that we use for anterior cervical ACDFs, the trimline retractors, because it gives us a lot of freedom of movement. I prefer not to use the tube or any of the expandable retractors. And that's the incision at the end of the surgery. We make 2 incisions, one on each side, and that helps to preserve muscle and early mobilization and early discharge. That's it. Thank you. If there are any questions.
So midline, if you go, that's a subperiosteal elevation. Here you have to cut the muscles.
I split the muscle fibers.
Oh, okay.
Some muscle fibers may need to be sacrificed, but it's a very small amount, similar to what we do when we are doing a tubular approach in the lumbar spine.
Post-operative pain?
Hardly any. I mean, we just use most of the time just PCT and oral painkillers.
Great. Yeah, thank you.
Thank you. Thank you very much.
Thank you, sir.
Next speaker, Dr. Mohan Ram.
Dr. Ashish Tandon is next. He has a flight to catch, so we are advancing his presentation. Dr. Ashish is going to speak on an interlaminar approach for a calcified disc.
Thank you, Savitr. Can I have my presentation, please? So, idea of this lecture is to sort of remove the myth that endoscopic interlaminar approaches cannot deal with difficult types of discs or stenosis or the hard calcified discs. So for me, the indications for interlaminar endoscopic procedure would be any disc or stenosis L3-4 downwards. I regularly deal with calcified discs using the interlaminar endoscope. All sorts of highly migrated discs can be handled. Central canal stenosis, foraminal stenosis, or spinal canal cysts. Now, calcified disc, we have been dealing with it regularly, and over the years we have found the incidence also to be increasing, especially in my practice, come across a lot of calcified disc. Not very clear the etiology. However, we have found that calcified disc somehow is more common in the obese females. They typically present with the severest form of leg pain, lower limb numbness, weakness, and they occasionally come with severe neurological deficit as well. One should be aware that there is a higher rate of adherence of the root to the calcified portion. So we all know what open surgery does and why we have sort of shifted to the MIS forms. As far as the endoscopic interlaminar approach is concerned, we have excellent outcomes. As far as soft lumbar disc herniation is concerned, there is reduced post-op pain, shorter recovery time. Patients can be mobilized in 4 to 6 hours. With the calcified discs, the challenges that we have is limited space. We need more mobilization of the root. And at times with the interlaminar endoscopic approach, it can be difficult to excise the disc, especially the initial part of the disc excision. As far as position is concerned, typical prone position with sort of hip flexed, nothing different. What I typically use even for a calcified disc is a 6.9 mm scope, give a 7 mm incision, and I typically use a 15-degree scope with a working channel of 4.3 millimeter. So once the incision is made, a dilator and sheath is introduced into the interlaminar space. It's very important. The more minimally invasive you go, the more accurate your incision should be. You dissect the lower part of the upper lamina, the inferior articular process. You drill to make the interlaminar window wide. Do a small phlebectomy and thereafter reach, dissect the root, and if there is extruded disc, excise it first, and only then you use your sheath to rotate and use it as a root retractor. So typically in an interlaminar approach, the sheath itself is used to retract the root. But what I was trying to emphasize is that don't introduce the sheath inside till you have sort of removed the extruded part. I'll just share you the video. Typically, we use regular instruments. They're long instruments, almost 30 centimeters in length. These days, ultrasonic osteotomes have been introduced and sort of specially for the calcified disc, and they're meant for endoscopic approaches. So I'll show you this video. This is a patient with a large L5-S1 disc. You'll appreciate on axial films. So this is the docking. This is the sheath in here. The initial part is the preparation. Here I'm separating the ligamentum flavum from the lower edge of the upper lamina. Here I'm separating the ligamentum flavum. Here you can see the neural component, using annular cutter to create more space, and thereafter going and cutting part of the inferior articular process as we do in any open approach. Thereafter removing the adhesions, and here you see the sheath is outside and there's a large extruded piece which I am excising. This is absolutely important so that you do not cause neural damage to the root. Once this fragment is removed, you can sort of rotate the sheath as I have rotated in here. This all is calcified. So there's a hump that you are seeing in here, and you see I'm cutting the annulus with the upcuts. So you can use osteotomes, you can use upcut, You can use the electric osteotomes that are now available. So you have a variety of options. Once sort of you have created the space, then you do the internal decompression of the disc. As you are appreciating, the root is quite free, though very much inflamed. We check, because it's a 15-degree scope, we check under the root for any fragments. This is another calcified piece which I'm teasing off. And then finally cutting here, you saw the axilla. The root is quite mobile and free at the end. This is another short video just to demonstrate the adhesion. So again, disc, I've edited the initial part here. A very small flavectomy. This is hardly 2 to 3 millimeter of flavectomy. Lot of adhesions in here. Again, create lot of lateral space. We need to cut part of the inferior articular process, part of the superior articular process. See that the root is free. You need to drill the inferior articular process, but superior articular process you can just upcut. Here I'm rotating the sheath, but it's quite tight. This all is calcified material. So here I'm trying to again dissect off gradually and separating the calcified material in which I would be upcutting. There would be some sort of ooze which you can easily deal with the RF, and this was the calcified part which you are excising. Now, when you are removing it, you have to be very careful that you do not damage your endoscope, because you can damage your endoscope. So just pull out the hard material with the scope so that you don't damage it. And finally, you can excise the internal large fragment. So all this fragment comes out. And the rest is the same. So over the last year or so, we have done 6 patients with the calcified disc. In one of the patients, there was out of proportion dysesthesia, which gradually recovered over 6 months. We have a lot of literature with excellent outcomes, but you have to be aware that you can cause damage with hard calcified disc. So you need much more space, more mobilization. So just one last slide for instrument care. Increased care in handling of instruments is required. When you're dealing with the calcified disc, there may be increased wear and tear of the equipment. As far as endoscope is concerned, you need to be very careful while you're using the osteotome or when you're removing the hard fragment. Please prevent heat damage. So the take-home message is it is effective MIS technique for even calcified lumbar disc herniation, though I must say that the learning curve is steeper. Extra care for handling the root during excision of the hard material and handling of instruments. Thank you so much.
Thank you so much, Dr. Ashish. In the interest of time, we'll just move on to the next talk. Up next, we have Dr. Mohan Rao speaking on endoscopic odontoidectomy.
Good morning to everyone. Thanks for giving me this opportunity to Dr. Manas and Dr. Sastry. Here I am presenting my small series of endoscopic transnasal odontoidectomy. This is my hospital. So So we moved from maximally invasive to minimally invasive, either microscope or endoscope for less pain, increased safety, faster recovery, less tissue damage, less scarring, and finally we use a lot of gadgets, so there is a precision in performance. So, and for any surgery, especially for the minimally invasive surgery, you need good imaging. Sorry, I'm showing the brain, but the same slide I use everywhere. So good imaging is needed, and good navigation system, and good retractors, circular 360-degree retractors, good endoscope or microscope, and you need a QSA sometimes, and neuromonitoring is totally functionally assessive at every point of the time, and in endoscopic surgery, especially RF is a must. So I did like in the last 5 years, 5 cases. So here I am not showing. So generally for the transnasal for odontoidectomy, we have 3 approaches. One is a transnasal approach, another one is transoral, and then posterior C1, C2 fixation. I mean, these are the approaches for CVJ. And here, these are the ways we tackle. For transcervical, we will come all the way retropharyngeal and remove how much we can remove. Transoral, I showed here. Transnasal, based on the nasopalatine line, we can remove. We use, this is how we can angulate it and how we will see the endonasal, transoral, and transcervical. Especially if you have the platybasia and basilar invagination, transnasal odontoidectomy will have an advantage. So patient positioning and instruments, skull-based endoscopic set, neuronavigation, neuromonitoring, debrider, curettes, endoscopic drills, Mayfield clamp, flexion. So for transnasal odontoidectomy, you need to give the flexion in the position so that directly you will be on that. And anesthesia, general anesthesia, and nasal access. Generally, I use the ENT surgeon to remove the turbinates and lateralize this and directly going on to the retropharyngeal space. And expose it to the odontoid. We'll remove like all the, it depends, like, you know, how maximally invasive you inner is totally depends on that. And then odontoidectomy, and then decompression and lateral stabilization is a mandatory for this. So what I did was like rheumatoid arthritis, spinous, basilar invagination cases. And so here, my first case is I'm showing like, so all the cases are not similar. You do changes, but basic steps I'm going to show here. This is a 68-year-old female with, 1 second, sorry. A 68-year-old female with neck pain, difficulty swallowing, voice hoarseness, and myelopathic signs. Polyarthritis is there, but rheumatology workup is negative. In this case, I mean, so this is the scans, MRI. You see the compression on the card, and this is the post-gadolinium. You are seeing the compression on the card. So in these cases, I feel like better to go from the anterior instead of directly fusing here. So first we will lateralize the turbinates, and once the first step is the first passage into the choana. So once we go there, once we check everything is good, then posterior septectomy, and then you need to flush this maxillary crest, because for sphenoids we will go all the way above, but here we are going down, so we need to flush it up and then go into the retropharynx. If we feel like if there is, I mean, especially whenever pannus is there, I do this step, retropharyngeal flap I'll prepare, and I'll make it like I'll keep it in the oropharynx for some time, and then for this, this monopolar is very useful. And once we remove that, then we'll go on to the bone. So directly we will be on the C1 arch and drill the anterior part of the C1 arch and For here, generally the 14 or 15 is the best drill, and then identify the tip of the odontoid, and then drill it all the odontoid, and then define all this is the pannus, like a granulation tissue. So debulk the pannus. So go up, generally we do like a round, upward, downward, superior border, inferior border, and finally you will see some pulsations. This is the removal is just like anything. And so generally for the woos, I use Surgiflow always. And once we are done with that, then again, so here you see that flap was placed back, and over that glue is, generally I put the glue. And this is the this is the intraoperative CT. And the postoperatively, we have mandatorily fused these patients because he removed everything. So the next case is a little bit different. This is a 14-year-old, previously operated, like a CVJ, C1, C2 fixation was done. But he developed a problem. When I checked, I did not find any instability in this. So he had a posterior fixation and almost tented up the brainstem. So this is the, if you see here, there's a big artifact. So tented up this one. In these cases, it is a little bit different. Previously, directly we went into the coena, but here, if you see the pictures, there is a lot of platybasia. And you have tip of the odontoid is over that. So I need to drill from here all the way up. So in this case, I started from the sphenoid. So this is a cella you're seeing here. From here all the way down, everything needs to be drilled out. So every case is different. It depends upon the pathology. And rest of the steps are similar, same as it is. Go and find the odontoid, C1 arch, odontoid, and then removal of this. Obviously in these cases, there will be some pannus. Some pannus will be there. So we will see at the end clear dura, dural pulsations, and then we will, in this odontoid is totally different. So I removed extensively, and closure will be with it's a simple closure. Just we will put again the same way. First is the typical case, and this is the again intraoperative CT showing total odontoidectomy. This is the on table, so we are happy. This is the pre-op, and this is the post-op. So pre-op MRI and the post-op MRI, and now the patient is out for almost 5 years. He was able to walk, but I lost him for the follow-up. Probably he's somewhere roaming. So it gives a good improvement in almost all the patients. Surgical morbidity is less. There is immediately we can feed the patient. We can give this is not unlike any other transoral surgeries. We can feed them. We can mobilize them immediately, and within 3 to 4 days, the patient can go home. So conclusion, minimally invasive approaches, especially transnasal odontectomy, still have the role in some of the cases. Even the posterior fixation is the first line, but in some of the cases it needs. So good outcomes will come, needs fixation of post-op is a must. Thank you. Thank you very much.
Thank you so much, Dr. Monrao. Up next, we have Dr. Praveen Salunke speaking on AAD reduction and posterior fusion with facet remodeling.
at the outset, I would thank Savitra for this wonderful opportunity, and of course, the organizing team. Yeah, so as we can see, the anomalies of CV junction, they're pretty complex. Yeah, so I'm just going to, they're pretty complex, and you can have assimilation, vertical, or the so-called basilar invagination. It compresses onto the cervicomedullary junction, giving rise to symptoms. This is how a C1, C2 looks in a normal patient. But when you look at the patient with a congenital atlanto-occipital dislocation, look at the deformity. The C1, C2 joints are quite oblique, not only in the sagittal plane, but also in the coronal plane. And that is the reason why the C1 slips over the C2. It's a glacial process. It's not something which is, a patient is not born with a congenital dislocation, is actually born with deformed joints. And depending upon the deformity, there's a glacial slip, progressive, dynamic process. And that's the portion. Having said that, the deformity, if you chamfer it off, if you make a wedge osteotomy, you can actually reduce it in any plane, in all the planes, and you can reduce. There's no need for transoral resection or removal of the dens, the compressing element. Look at the joints, address the joints, the deformed joints. So that is the whole idea of this concept. Of course, you have to look at the anomalous vertebral arteries which might cross posterior to the joint, and while the whole concept here is of the posterior joint reduction, and of course you can injure the vertebral artery, so that needs to be taken into account. And if you look at this now, this is a post-op image where you can see that it is reduced completely. There's no need for actually a transoral resection. So this is an example. This is a 35 years old male who has significant compression at the cervicomedullary junction. And if you look at the CT, the X-rays, you can see assimilated arch of C1 with C2, C3 fusion with both vertical dislocation as well as anteroposterior dislocation. So it's not, traditionally is the so-called basilar invagination is actually a vertical dislocation. And these are the joints. You can see they are significantly deformed, oblique. That's just the lines to make, to give a clearer picture that these are pretty deformed. We also got a angio done, so that's a norm. And this is the position. Usually it's on an Allen's table, or you can, if you don't have it, but make sure that the eyes are not compressed. The post-op, this is the fluoroscopy, did not show any reduction. So through a midline incision, the C2 spinous process and the occiput is exposed, and subperiosteal dissection is the key. You don't need to use too much of monopolar, just a dissection of the C1 and C2 that needs to be exposed very clearly. The undersurface of the C1 arch can be removed to expose the posterior surface of the joint. The C2 nerve root ganglion can be cut. I used to do that initially, but now I don't do it anymore. In the last 300 cases, I haven't done it because you can easily mobilize. The skeletonization of C2 is possible, the nerve root ganglion, and you don't need to cut it actually. But in the initial days, it's better you cut it. Once you remove the C2 nerve root ganglion, it gives you a panoramic view of the entire C1, C2. So now you can put some distraction on the occiput and the C2. Now that opens up the joint a bit. But if you distract too much, excessive distraction, it's actually going to be counterproductive. You can see that the C1 is going to be like the C2 anterior point is going to be like a fulcrum, and it's going to deviate inside, giving rise to compression of the dens. So that's the exposure of the C1, C2 joint. You can see that on the left side, and it is dislocated both anteriorly as well as laterally. So this is insinuating an osteotome just to get an assessment of how deformed the joint is. Once you do that, you can see that it has become completely mobile. You can actually start moving it around. And that's the concept. The deformed joint, do a wedge osteotomies to correct them just like normal patients or normal individuals. So make them flat in all the planes, not only in the sagittal plane, but also in the coronal plane. So drill off a small portion of the C2 medial, posterior medial surface of the facet. Once that is done, you can actually start the overhanging C1 facet is very clearly seen now. And that tip, that small little antero-inferior portion is the point which needs to be drilled off, because that is the one which is preventing its reduction. So it's marked with this asterisk now, and the whole, you can just use the drill as a lever. You can just lift it up and down, and you can assess that portion of the facet that needs to be drilled off. Once it is done, the end point is you can see the entire anterior capsule from medial to lateral. So that indicates that the joint has been freed completely. Of course, too much of drilling, it did happen in a couple of cases initially, that it was left with very little bone stock for screw placement, and too less drilling will not allow you reduction. So the idea is to release the joints completely while correcting the deformity. That's the most important thing. So one can use O-arm if you have the facility, but it does help in the initial cases, of course. So I prefer to put in a isthmus, a pedicle screw in the C2. I don't like putting in a pass screw because of the fear of the high-riding vertebral artery getting injured. So the medial portion of the isthmus, that's the point where I would like to put in my screw in. And at times, even if you have a high-riding vertebral artery, you can actually mobilize it by putting in a small dissector just on the medial surface of the transverse foramen to prevent any injury while you're making a trajectory. The trajectory is also drilled into the C1 facet, where about 2 millimeters in the midpoint in the inferior surface, and just directed about 10 to 15 degrees cranial and 10 to 15 degrees medial. So that is, you can also put in your instrument in the joint space, so you get a fair bit of idea how much bone purchase are you getting. I prefer to get a bicortical purchase, so you need to put in about 20 to 22 mm of screws. And this is the spacer which we have devised and designed. So it has a 60% graft window, and that spacer along with the bone. So the idea of spacer is not exactly to distract it. It's actually the bone that has been drilled off, that needs to be replaced with something. So we need to, if you put in just bone chips, it's going to get resorbed, and there's going to be settling. So because of that, we just put in our spacers with bone chips. And once that has been done, so further manipulation, you just don't jam the joints. You have to, the spacer has to be slightly smaller than the joint that has been drilled. Once it has been done, standard C1, C2 screws, pedicle screw, lateral mass screw, and this is the manipulation which I was talking about. You can just, because the joints are released now, the spacer is not jammed, you can just manipulate it any direction you want to. So this is the craniocaudal, and this is the lateral alignment. So you can see that derotation. So you can achieve rotational alignment, lateral alignment, antero-posterior alignment. So it's the concept is of a multiplanar realignment and not just antero-posterior vertical realignment. So finally, we just have to jam the spacers. Now we have to make sure that you have compressed it. The idea of compression here is not to aid reduction. It's just that the spacer should not slip. That's the most important thing. Once that has been done, the same side is repeated on both the sides. Decorticate the surface and put in a lot of bone graft so that it fuses finally. Eventually, we want it to fuse in the reduced position. So that's the most important thing. So the midline, I don't use too much of C-arm these days. You can just look at the midline and assess. So this is an example where the O-arm was used, and you can see the placement of the screws is all intact, good reduction. So these are a couple of examples. Antero-posterior vertical dislocation, good reduction. Another example, not only is it an anterior vertical, but also in the rotational plane, the lateral plane. Another example where there's a lateral tilt of the C1. You can see this is a lateral angular dislocation. It's not just antero-posterior vertical or basilar invagination. It's actually the C1 has moved lateral. It's moved lateral to the C2, C3. You can see that, and that can be all corrected by these maneuvers. Another example, you can see that again the C1 is lying lateral to the C3, and you can just swing it back into its position and correct it. This is an example where most of us would say it's not doable by just maneuver, but here's the result. That's another example. So it's all multiplanar. So that's, thank you for your attention. Thanks a lot. Why do you want to include C3? That's my question. I mean, see, the concept here is these patients already have block vertebrae, so the range of motion is significantly restricted. So if you include multiple segments, it's not going to serve any purpose. The thing here is most of it is actually the dislocation is at the C1, C2. So you correct it, and the weight-bearing segment is actually the facets of the C1, C2. So once you stabilize it, there's no need to include any other level.
Dr. Salukya, it's an excellent series like you have. So how are these bone fusions, and how many of them come back with settling and again basilar invagination or compression happening at the CMJ?
So approximately 5% of them do come back with some kind of redislocation. Settling, if you ask me settling, there's approximately 1 millimeter or 1.5 millimeters of settling, which is seen in many of our patients, not in all, but many, but that has never been clinically or radiologically significant. So, because obviously we have decorticated the entire facetal surfaces, so we assume that there will be some settling because of the metallic spacers which we are using. So we actually compensate for that.
How do you assess the bone fusions?
So the cortical margin has to be intact from the anterior surface of the facet, the posterior surface of the facet, and the space which has been created, the graft window. The bone should be seen going from the C2 surface right up to the C1, one single bone.
Thank you.
Good morning, everyone, and it has been a privilege to be here for the last couple of days. And thank you, Dr. Manas and Dr. Savita. It isn't corpectomy. I think it's anterior cervical discectomy and fusion, but the same thing is done in corpectomy. And it's one of my most favorite surgeries, and the steps are very simple. I think all of us are doing it, but they are repetitive and need to be done in that manner, I think. Warm regards from Amrita Hospitals. So we'll quickly move to the procedure straight away. So the first step for all neurosurgical procedures of brain or spine is positioning. And as you see, I like to use a Gardner-Wells traction device. And more importantly, we need to keep the neck slightly in lordotic fashion. And then I use a towel and soft cotton inside. The other thing that we notice is we need to pull down the shoulders. We need to be very careful while doing this, because if you put excess of traction, we are bound to injure various neural structures like the brachial plexus. We have to ensure that the armpits are padded with cotton, and you have to personally see to it, because many of the time your tech may just forget about it. We'll skip the landmarks. Everyone knows these. So all surgeons like to draw, and I also like to do it every time for all the cases. You need to inform the NSSA that yes, you are right-handed, probably you'll do it from the right side. They'll put the tube to the left side, and they will fix it very well. This is important because your intra-op, you may have to, you will be giving traction to place to your cage. So every time I draw the clavicle heads, and then I sort of mark the sternal notch, draw the midline, then I palpate the sternocleidomastoid medial part, like draw it. And then after the routine radiographic localization of the level, we can use a horizontal incision for single level, or we can use a vertical incision if needed for corpectomy, or more than one level. So I have encountered one of my junior colleagues who has done injury to while dissecting. So the important part is what to cut. In this surgery, there are just 3 layers to cut: skin, platysma, and the fascia. That's all. Rest all needs to be blunt dissection. Sometimes the omohyoid might come in your way and C5, but you can just cut it off and then later suture it back. So the trajectory first, what I do is skin and the platysma are cut. Then you can do a subplatysmal dissection, superiorly and inferiorly, or along the sternocleidomastoid, just to have more space. Use your index finger. That's my practice all the time. I use the index finger, palpate the carotid with the pulp of my finger, and then inform the anesthetist that I am touching the carotid. There might be some changes. Beware of vagus, which is also there. And then gently guide your finger and land on the bone. Once I do that, I usually use a retractor, a lungeon back, and then just pull it, ask my assistant to pull it, mark the disc space, which is always a swelling, which you can feel with your finger, and you can see it with a needle. So this why I like to stress upon using the microscope right from the beginning. So once it is marked, I bring in the microscope, and the most important part is your assistant. In my case, is usually a junior colleague or a resident or maybe a nurse. So I have to ask them, do you see what I see? And once they are comfortable of what I'm seeing, then yes, we move ahead. So again, I'm palpating the carotid. I use these retractors, which are do not sort of dissipate current. These are from Medtronic Streamline. You can use any other retractor, but just have to be careful. So here we are now marking the entry point, making no fear at all to go through the disc space where we have marked, to burn it so that we don't lose sight of what it was when we remove the needle. Then we use monopolars and scissors alternately to see the longus colli. That is the midline mark. The longus colli is the most important part, which will guide you where your midline is. There's no need to mark on the bone or anything. Then with a well-guarded monopolar, this is, I feel, is a very important step where you and your assistant have to work in tandem under a microscope, where we lift the longus colli. You have to lift it so that on both sides the retractor blade sort of sits under it, and you can stabilize the retractors. You have to be very careful while using the monopolar, because you might end up injuring structures medially, which are trachea and esophagus, and you don't want to do it. Just enough of bone to be exposed superiorly and inferiorly where your plate will go in. And you see how when I'm trying to lift it on my side, my assistant here nicely releases the retraction so that there is not much of a retraction when I'm pulling the longus colli on my side. So I'll just forward it, I think, if we can. Sorry. So this remaining is just a performance of a discectomy with a knife, and then can I just have the, excuse me? Maybe I can't forward, maybe I'll just skip to the next one. Okay, thank you. So if you just forward it, so here, after performing, putting the retractors in, you are again the midline, you incise. The idea to show here is that you need to drill. You'll need posterior ossiphytes will come at the base of the superior vertebra, the rostral one or the caudal one. I am using a cylindrical drill, which is quite helpful because the inferior part of it is quite flat and you don't injure any structures, and always carry sense of 1 to 2 mm and not more than that. I prefer to use a vertebral distractor rather than pin-based distractors, because one, sometimes in osteoporotic bones, you might fracture the bodies, and other, I feel that my bone surface needs to be absolutely virgin for the plate and the screws which I played, and so I'm afraid of putting the pin-based distractors. Next is about the drilling of the posterior PLL, drilling of the posterior osteophytes and the PLL. For all our cases, I prefer to remove the PLLs to achieve adequate decompression. Here we are trying to achieve lateral decompression towards the uncovertebral joints. One needs to be careful and mindful that if you go more laterally, we'll end up injuring vertebral arteries. So we have to be very careful. Again, the same drill as you see, we have encountered a osteophyte. Anything which looks like wax that I feel is it's an osteophyte, and you need to drill it completely down until you reach the ligamentum PLL. Sorry. So again, similar demonstration, just a different type of drill here, a round drill to so eggshell core out the osteophyte, and then use a 1 mm or 2 mm kerrison to fracture it out. And you'll see in this here, we start using the very nice instrument, which is after decompressing all the osteophytes, which is a sharp hook, and in the sharp hook helps us take out the, sorry, it's not moving forward. Okay, I think it's stuck. So we use a sharp hook to lift the PLL and use a 1 mm kerrison punch, and I usually use it with my right hand, the hook, and then transfer it to the left side, and then use a kerrison punch to cut the PLL completely and release the neural structures.
we are hung here. So why I feel in releasing the PLL is important, because sometimes certain disc material can always be lying behind the PLL. And there are, in beginning of our career, we are often afraid of not doing lifting of the PLL, but it's quite safe and quite easy if we are careful about how much we are going in. So in most of these drillings, I keep my suction always inside. I don't let my assistant use the suction. I keep it on the bone above or below. That gives me a perception that, yes, I am at this height. And with that, I can use my other hand, the right hand, to go in, and I have a good depth perception. So I think we are literally hung here. Should we stop it or just go to the next slide? Okay. Sorry about this. More up. Up, sorry. Back up. Can I just take over from here? Yeah. So I think we were here, and this is the slide show, current slide. So again, you can see here the sharp hook going in and trying to dissect out the disc which is lying underneath here, the PLL. It is ruptured through the PLL, and we can carefully tease it out. You'll see the dura peeking out in between, a sharp, white, glistening structure. And once you see that, we have to be very cautious, use extreme zoom in the microscope, and try to take out the PLL using upcuts 1 and 2 mm, and you can achieve a very good decompression. So rest of the surgery is quite straightforward. This is called, I call it end plate carpentry. We should not destroy the end plates and just use probably a curette to take out the soft tissue. And these are all theoretical, but more importantly about the plates. Before putting the plate, I think it is very, very important to ensure that the surface of the vertebral bodies have been removed of all osteophytes. Anything that is wax-like, we should drill it off or use a bone nibbler until you encounter slight bleeding. The moment you encounter slight bleeding, you should stop, because you don't want to destroy the vertebral bodies. So this is just a small short clip to show we are putting a lot of traction on the head through the Gardner's traction, and then inserting our cage. Here I'm using a coalition device, which is sand-alone system and it's quite simple. You don't need a plate over it. So once the cage is in, we remove the traction and the weights and let the bone settle back on. So this is probably the last video. Nothing, is just end plate preparing device and then a peak cage going in. The idea of this clip is to just show that when I put the plate, I always use these pins in the direction you want to use your screws. The screw should be pointed toward inward and superiorly in the above vertebra, and inward and inferiorly towards in the lower vertebra. The direction of the pins after C-arm, if you are satisfied, actually helps me to put the remaining 2 screws, which I put first, and once these 2 are placed, then I remove the pins and place the other screw. This helps us achieve a very good trajectory. So closure is straightforward, just 10 minutes, or maybe some time you have to spend on hemostasis, but always a drain, then platysma to be sutured with Vicryl and monocryl closure. So there are complications, but I feel for all our patients, we should inform them that post-op for 2 days, they will have difficulty in swallowing. There is no way around it. I don't think 9.5% Courton literature is correct. On most, like majority of them do have. The other complications can be avoided if we are careful and we use good illumination and magnification. Thank you very much. So it depends on the level. It's not ideally required to use a lot of traction. Around 2 to 3 kgs would be more than enough, because you just need slightly lower doses. It is not mandatory to use traction. I just find it convenient to fix the head so it doesn't move a lot.
Thank you, Dr. Satyakam. Up next, we have Dr. P.K. Sahu speaking on anterior cervical disc replacement.
A very good morning to everybody. I thank Dr. Panigrahi, Dr. Sabitra for calling me and the organization for organizing such a beautiful spine congress this year. And my topic has been already covered. Most of the part has been covered by Dr. Barua. I have but few points I would like to stress on that. That when you go positioning, he has very nice positioning, extremely important. Traction is not required. If you are doing C5, C6, C4, C5, there is no traction what is required. You just put the shoulders, if a short neck, and then you put also a strap on the head. There is no need of putting any traction when you are doing a cervical discectomy or cervical disc replacement. This disease is refractory to medical therapy. Patients generally experience rapid recovery, improved arm pain, and better quality of life. But life is for moment. If you fuse, you lose. It restricts the neck movements and probably puts additional stress on a non-fused disc species. That is why this cervical disc replacement has come, and these are being practiced in few of the centers well. The reason, as I said, because of there is infusion symptomatic adjacent disc level at 2 to 3% per year, and up to 15% patient may require a second surgery because of adjacent segment disc degeneration. So these are as like in other case, surgical indications are remain the same. The aim of surgery is here, as a matter of fact, after doing a cervical disc replacement, it allows the individual to go to his duties much earlier than when you are doing a fusion. And you have to put a collar. The surgical objectives are decompression of neural structures. You replace the worn-out disc. Like any other situation, the surgical objects remain the same, what he has described. In a person who is elderly, irrigation system, you have to, is important. Exposure, identification of disc spaces. That is very, he has already described. Single site exposure and microdiscectomy. If it's single site, you give a transversion. Even for two sides, you give a transverse incision along the right side. Normally, approach from the right side. Most of the European people operate from the left side. Any remnant disc has to be removed. Total disc has to be removed. As I said, posterior osteophytes has to be removed. The next phase, implant size selection, extremely important. When you are doing the implant size selection under image, whether single level or two level, you have to see that proper size of the implant is put. This is extremely, otherwise there will be failure, there will be displacement, there will be dislodgement of the implants. Therefore, one has to be extremely careful of this size, and you have to select a proper size. This can also be done prior to surgery also, but at the time of surgery, you have to implant size selection, extremely important. Next step is rail preparation. This is a step where the disc fits and remains there, doesn't extrude, does not come out. So therefore, this rail preparation to fix the implants in size. This is also a procedure which has to be done carefully. And after the rail preparation, then you size as per the size of the prosthesis. As per the size of prosthesis, you have to do the rail preparation, and then you bring the implant, and this is how you put the implant. And it has to, you have to see that when you are putting the implant, this should not come above the surface of the, when there are a lot of osteophytes, multiple level disc degeneration, implantation for a single or two level. And cervical are not required to be used. Once you do cervical disc replacement, as a matter, no dressing is required to be put. And in our case, two cases, they had temporary hoarseness. And if you put a cervical retractor who is radiolucent, you will not find the complications are happening like esophageal perforation, nerve injury, vascular injury. You will not find these things. You have to carefully put the retractors, and which protects all the structures extremely well. It has to be a radiolucent retractor. And these are the things we have done. Suffice to say, I will not go to details, but we have done almost 320 cases in a period of 20 years. The follow-up is up to 20 years. And these are the level of disc. Neck pain, as you have seen, you will find neck pain, arm pain, substantially reduces in a case of cervical disc in contrast to a cervical fusion. So therefore, whether it's arm pain, neck pain, or visual arm, it is much better in a case of cervical disc replacement than in case of cervical fusion. And these are the, you will find post-operatively 2 months, 6 months, up to 1 year, you do only X-ray. You find the implants are always in position. These are some of the cases. C4, C5, C5, C6, C6, C7. During follow-up also we found the implants and the movements are all present. So these are the cases. This is another case. So this is fast post-op, no dressing his foot and he can move full movement and say X-ray, this maintained well. So these are the few of the cases. I'll just show a short video of the case. This is transverse skin for single, 2 level, even up to 3 level, single transverse starting from midline up to anterior sternocleidomastoid. That is what required. Platysma is divided along the line of skin incision. And then if there is any osteophyte, you have to remove all the osteophytes. You do a standard discectomy. What has discectomy? It is a microdiscectomy. Can you fast forward this? Discectomy. And always try to cut the posterior longitudinal ligament. Slowly, you go on, slowly, so fast. Little faster. Move. You can show me. You have an osteophyte remover. There is some osteophyte that can be removed by the osteophyte remover. You should not put the number 1, number 2 punches or the off cuttings. Little faster, can flip. So this is what is important, intradiscal sizing. And see under image it fits properly. 5, 6, 7, 8. These are the sizes available, and most of the people they fit to these sizes. Thoda faster. And thank you very much. Probably. Anyway, and this is how I have told this story. This is how you do. And normally the complication much less. Results are extremely good. I will say that there are certain complications. What you say, you avoid those complications if you take precaution during each step of the procedure, positioning, during your cutting, retractor placement, and taking the image intensifier properly at it says, you avoid almost all the complications. Thank you very much.
Thank you, sir. Sorry about those technical difficulties with the laptop. Up next, we have Dr. JKBC Parthiban, who will speak on cervical lateral mass fusion.
Yeah, this is a very old technique. And actually, when we started itself was a very old technique. And so it's become very oldest technique. And you can see that from 1991 we started, and now today is nearly 33 years since we started doing it. But I'll show it in a simple way so that the young generation can see it. The earlier seniors will know that, but the young generation needs to know the lateral mass fixation. As ever since it came into picture, it made our life very much simple in the posterior surgery. And lateral mass is one of the thickest bones, very, very thick bone. You can see the very thick bone which holds both the superior facet and also the inferior facet. And so the thickest part is have to be used. How we can use it, and there are few lines where you can see here, this one and this one. These are the facet joints. This is the facet joint. This is the facet joint. So this is the lateral mass, spinous process, your lamina. This is the lateral mass. Again, if you wanted to see the lateral mass, there are some degrees some 35 degrees is very, very common. Generally, it is 35 degrees at C4, C5. And we should know what is just in front of the lateral mass. You can see the lateral mass. You see this, but you don't see what is there in front. And medial half, you can see vertically, is formed by the vertebral artery. That is very, very important thing that you must know about it. Just simple thing you have to remind is that the medial half is occupied by the vertebral artery and the nerve root. The nerve root descends like this. You can see the nerve root, the dorsal ramus and the ventral ramus. It goes like that. It is ventral. If you look at this, this nerve root is just behind the vertebral artery when you see from front, but when you see from posteriorly, it is the other way. This is my own diagrams, and which I made it very simple in my book also. You can see this is the vertebral artery, and the nerve crosses like this from superior medial to inferior lateral, and this is the empty space. That is the safest space. So superior lateral quadrant is the safest quadrant in lateral mass. Whatever you put there, no issue. But then you have to see the MRI and the CT with angiogram to find out is there any abnormality. So this is another picture which will show you. And this is the line diagrams. These line diagrams you can see the textbooks of B. Ramamurthy those days. And if you see, if you want to push one screw from here to anterior, just 10 millimeter screw is sufficient, which Roy Camilli first did. Roy Camilli just simply put straight in, just 10 millimeter small screw. And then later on, the big giants came, tried to change it. They angulated the screws from medial to the center from laterally, because superolateral is the safest quadrant. And there are so many schools. There's so many schools. If you carefully see all these degrees and whatever you say, it goes from the central, the highest headlock point of the lateral mass towards the superior lateral angle. That just you have to remember this, and that you can see it in this picture, how you can angulate your drill, all your directions. Now, this is the screw entry point. You can see here, if you see this is the lateral mass, this is the entry point, and then you direct it like this. And nothing but take a nice good drill which you have, micro drill, and 2.7 or 2.8 millimeter micro drill, you can use it, and then you can drill that superolaterally and then put the tap, the same thing. And before you put in the screws, you can also do the facet cleaning, so that you can put your graft there, and then put the screws. Then put the screws of any type, anywhere you like. We could do it after a laminectomy also. You can do without laminectomy also. Then finally you tighten it up. So simple, elegant procedure. And I'll show you a very small video how to, yeah. There is no volume. We expose the spine, lamina, and the lateral mass completely to the lateralmost edge of the lateral mass. This is the medial facet line. It is drawn just lateral to the laminar edge and the junction of the lateral mass. And now I am making the lateral facet line. This is the superior facet line, and the next one is the inferior facet line. This square anatomy is the lateral mass. And draw one line from rostral to caudal with the midline, and then one between the facet lines, that is the intrafacet line. These lines join together at the midpoint of the lateral mass. The entry point of the screw is slightly medial or inferior or superior depending on the authors. And the superolateral quadrant is the safest,
because the medial quadrants, anteriorly we have the vertebral artery, and the nerve travels from the superior medial to the infralateral quadrant. So the entry point must be in the midline or medial to the midline and directed laterally and superiorly depending on the degrees. Like for example, for Magal it must be 40 degrees parallel to the facet joints and 30 degrees to 35 degrees laterally. You can see that is the facet joint and that is the angle where you can use it for Magal technique. You can use one probe to decorticate at the midline, slightly medial to the midline, decorticate with a probe, on, and then later on use a 2.7 mm diamond drill bit, a long handled micro drill. Enter into the midpoint and then direct it towards superior and laterally, slowly and gently until we reach the proximal cortex. Once we reach the proximal cortex, we feel the resistance and a little bit more of drilling can help to breach the proximal cortex. You should not use force. After that, you can use an appropriate tap. You can see the line of the tap and also the screw. Now, a 3.5 mm polyaxial screw is placed, directed, and this screw is placed nicely. If it is not going well, you can still more drill better and make the anterior cortex breached. Like this, you can make the drilling points and the direction of the drill superior and lateral in all lateral mass. One should practice this, finding the midpoint and drilling. After drilling the screw points, you can do the laminectomy and shape the facets for putting the grafts and then apply the final screws. You can see the direction of the screw which is going superior and lateral. Like this, all polyaxial screws can be placed one by one, gently.
Okay, so like this, you can do gently. It's very simple technique. But only thing is you keep repeating and master it. That video is about nearly 15 years old video. We are also very much senior, so this is the post-op, and you can see the post-op pictures. So you can use it from subaxis C3 to C7. You can use it even in complex cases like this. You can use it. So thank you very much for the opportunity. Thank you.
Thank you so much, sir. We're really running short of time. Can we have Dr. Krishna Sharma next, please, to talk about cervical pedicle screws?
Good morning. It's another way to fix the subaxial spine, the subaxial cervical transpedicular fixation. Which one do I press? This one? Okay, right. So there are different pathologies that make the spine unstable, and we feel that the fixation should be biomechanically strong, rigid, and stable, including all three columns, and we have to preserve the neurovascular structures and maintain the function. And I believe this can be achieved by transpedicular screws through posterior approach. And transpedicular means from the facet you go to the pedicle and into the body, so you fix all the three columns together. I was lucky to, Abumi from Japan was the one who popularized it, and I was lucky to learn from him when he came to Nepal once. And this technique relies on an accurate knowledge of the three-dimensional understanding of the lateral mass and the pedicle morphology. The most important being the angulation of the pedicle axis, which is 30 to 50 degrees, unlike in the thoracic and the lumbar one. And the diameter gradually increases from up to downwards. And we can, does this work? All right. Right, okay, fine. So as Dr. Parthiban also told us that the vertebral artery lies on the medial part of the lateral mass, and the root goes from the inferior one. As he has divided the lateral mass into the four quadrants, the entry point is little different when we put the lateral mass. And as he also said that the safe zone is the superior and the upper quadrant. Now the positioning is neutral. Proper positioning is prone and neutral with the shoulder strap. This is because sometimes if you have to include say 6, 7, it may obstruct, and we really depend on the x-rays for correct direction of the pedicles, the screws. Yeah. Now important is that we make a very long incision, because we have to expose up to the lateral margins of the lateral masses bilaterally. And we have to scleronize the lateral mass, and we have to define all the edges of the lateral mass so that we can accurately find out the entry point. And angulation, to make an angulation of 20 to 45 degrees that is parallel to the angulation of the pedicles, we need quite a wide exposure. And of course, X-ray, I use X-ray, I use fluoroscope. If you don't have, you can use an X-ray. I don't have a navigated guided, but you could definitely use it. Now the entry point is little different. We go from lateral to medial, and it just almost at the corner of the lateral mass, superior and lateral corner, that is 1 to 2 millimeter inferior to the caudal edge of the inferior articular process, and 2 to 3 millimeter medial to the lateral edge of the lateral mass. This is the entry point. And what I usually suggest is we define the most cranial and the caudal entry points, and likewise then draw a line so that we know where to put the in-between screws. That way it will be easier and less effort to put the rods later on. These are the very few instruments that we all need. It's just a handrail, a tap, a pedicle finder, an owl to make the initial impression, and a sound to recheck. In every step you go forward, you check with this. The most important step is maintaining this angle of insertion. It is 20 to 45 degrees. And to facilitate this angulation, I usually ask my assistant to put the finger and pull the spinous process from the opposite side so that the lateral mass is elevated on your side. So angulation becomes little easier. You have to steady yourself, make yourself comfortable, and we should choose your access well. And we use both the hands. We really have to be very careful when we advance the drill and stop wherever we feel that we are not comfortable with. The angulation, as we know, depends on the different pedicle, the vertebral bodies we are using, and it goes from up to down as we go down. And I don't prefer to, and I don't advise for a freehand insertion of the screws. Now, the first step, I'm sorry I don't have a video because it didn't work well and didn't come clear, so I'll explain it step by step as we go around. So first, as we have marked the entry point, we expose the lateral mass right up to the A's, and right to the superior and the lateral margin of the lateral mass is the entry point, a few millimeters from this one, and we mark with an owl. And once we mark with an owl, I usually use a hand drill. I don't use a electric drill because it gives me a more control. And the angulation is very, very important to make it it's from almost 45 degrees, 30 to 45 degrees. And caudal and cranial angle is made according to what you see in the X-rays. So it has to be an X-ray guided lateral view to guide you where you are going, cranial caudal, and angulation from 45 degrees is what I would suggest. And with this angulation, we slowly drill inside, and usually the pedicles are almost 1 centimeter, 10 millimeters. So if you are in, let's say, 11, 12 millimeter, and there's bony which you feel, you can be pretty confident that you have bypassed the pedicle and into the body. Nowadays I feel safer with this hand drill, which marks the 20 millimeters, and I handle with this. These are the pedicle finders. If it is a little tough, I use this one. And the sound is very important that we check it again and again in every step that we are right in the track. The preferred is, of course, the parallel to the upper body. And this, using a tap, we make a track and then put the screws. Right. So we insert 2/3 of the bodies, put the screws on the both sides, then only put the rods, bend the rods to re-establish the cervical lordosis, and post-operative collar is only to control pain, but not to probably stabilize. This is a very stable construct, so you don't really need to do it. And after insertion, we do laminectomy, not before that, because the anatomy will be distorted with the laminectomy. So this would be the final picture. So there's a good reduction, no injury. The weakness of deltoid muscle due to the C5 root is often seen in 35%, but mostly it is transient and recovers. And malposition and breaching with the pedicles is been quoted very high, but I don't think that is so. And mortality is due to the respiratory tract infection, secondary to the cause of the injury, instability, not the procedure itself. I think I'll stop here since we're talking about the procedure only. Do we have time? No.
Thank you, sir. Can we have Dr. Ellen Tripathi next? And the next batch can go down to the OT at 11:15.
Good morning. What a pleasant time I'm having since yesterday. Thanks to Manas and Dr. Savit and a wonderful team of KIMS organizing this conference. And I met so many friends here. So today, within the stipulated time of 10 minutes or less, I'm going to show you some very common presentation of uncommon pathologies. So one is uncommon, the other one is not. But you will know what I'm trying to say during my presentation. So first, let us see one extradural cavernous hemangioma. As you know, this is quite rare, and of course, we've seen that in vertebral bodies and intramedullary location. but 4% of all epidural tumors can be cavernous hemangiomas. And it was reported in 38, sorry. So the vascular elements can be from the primordial plexus. And you can read it all in the books. And the cavernous hemangiomas are vascular channels, as we know. And they appear frequently in the intercranial structures. We all of us know. Only interesting is that we don't have the popcorn appearance in extradural because there is no blood-brain barrier here. And they are all washed away. So only 51% are extradural from all the spinal vascular lesions. Now, they develop anywhere along the spinal canal, but commonest in thoracic. Ours was also on the thoracic. And the present history is around 40 years. And so slowly progressive. This patient, I'm going to show you a short video, actually was seen by a few neurologists and neurosurgeons. But they were imaging at the wrong level, unfortunately. And sometimes neurologists, of course, I have nothing against them. They are great friends. Especially orthopedic colleagues, they look at the lumbar spine for obvious reasons, and they forget the proximal part of the spinal cord, which we are very, very, meticulous about. So one thing I have to tell the residents who are about to take their exam, if you get such a case, please look into the MRI carefully. These cavernomas are ovoid in shape. They're uniform T2 hyperintense. And their lack of anatomic connections with the neighboring. So what you confuse with is a disc or probably a schwannoma or a meningioma. That is the commonest. So 1, 2 is meningioma, schwannoma. And third, you can keep a cavernoma if you find this positive. They are brilliantly contrast enhancing. And the absence of popcorn I mentioned already. So this patient I'm going to show you is actually 55 years old. And he presented with dorsal pain radiating along the chest wall for last 2 years. And nobody thought about it, unfortunately. And he had slowly progressive spastic gait weakness. And there was progressive weakness more on the right than left. And of course, it was. So this is what I want to show you. If you see such an MRI, for the resident's point of view, you look at this is extradural tumor, broken bamboo stick appearance. We used to do myelograms, and we see broken bamboo stick appearance. And you see how bright it is. It's very, very bright. And in T2, and if you give, this is T1, if you give contrast, it is brightly enhancing. And what you see is, of course, part of the tumor is going in the foramen. So that is what fuxed me, especially. And I didn't understand that this could be that brilliantly enhancing. So that is how the video is there. And if I can show the video, if it runs, so that's it. So this is after the laminectomy. What you see is laminectomy. I do laminoplasties or hemilaminectomies in the long segment ones, but one segment we localize nicely with the C-arm, and that is, you see the tumor. This is on the right side of the patient, and this is the left, this is top, this is bottom, that is D8, 9 level, and I'm trying to drill the lateral masses a little bit, the facets, so that that's the tumor. You see how it is looking. And while operating, I did not actually think it could be a cavernoma. It looked a little red and different from a normal schwannoma. I was looking for the nerve root. And the nerve root, you will see the distal one going like here. I was changing it and then took a little bit of nerve root out, because if you leave behind tumor, it can come back. And so that's I'm trying to widen the foramen there, and with the drill and, of course, the carescence. You look at the tumor. It was a bit spongy, and there's a lot of extradural venous plexus there. But it didn't occur to me until I got a frozen section report. But it was slightly different. So that was the MRI picture you saw going into the foramen, exactly like a dumbbell tumor, extradural one, and opening the foramen posteriorly and changing the nerve root. Now, thinking that it was a schwannoma, I was trying to see the proximal root, but I didn't get any. Unfortunately, I think the proximal root got torn, and what I was encountering was all this. It's quite vascular. I mean, not that it could not be tamed, but a lot of venous plexus, you see. And this is what was brilliantly T2 hyperintense and T1 post-contrast enhancing. So, and after I removed it, there was a little bit of CS oblique here, you see. And I'm trying to pull the nerve root out medially to the canal so that I could cut a little bit of tumor, which is normally we see in schwannomas. Mostly schwannomas, as you know, for the resident's sake, is intradural, but some of them can be extradural, and some of them can be dumbbell in and out of the canal. So that's the nerve root. This is faster. I'm not trembling yet. I haven't got any tremor yet. That's a little faster video to match the time. And Sabit said that you have to finish within 10 minutes. Thank you. It's a wonderful conference. This morning I went to Jagannath Temple and Tirupati Temple to offer my prayers. Fantastic city, Hyderabad. I really love it. I came after many years and landed in the airport. It was like a Washington, D.C. airport. So that's a fact because I saw some CSF. I normally use some Tishil, but this patient was actually a corporate patient. So we were not allowed to use certain amount of. So that's that. And then quickly, if I can go to the next slides, friends. Thank you. So just quickly, so the next slides. Where is it? Yeah. So the next one. It is in the same presentation. That will be, is it there? That will be syringo-subarachnoid shunt. Same presentation. I thought it would come. Vijay, na?
Yes.
Oblique. Thank you. I remember your name. In spite of the tumultuous night, which we survived, but we had a great time. Thank you. So it's coming, hopefully. Anyway, the next case I'm going to show, a very short one, is, this syrinx. I'm glad my friend Atul is not there. The moment you utter syrinx, you will say C1, C2 fixation. But this one is slightly different. Very segmental syrinx. Many such small syrinx we see in MRI, And people come especially from neurologists saying that, doctor, I have got this cavity in the spinal cord. I say, hang on a minute, that's not a cavity, that's a congenital. So congenital small syrinx is fine. But if you have a syrinx like I am going to show you, it slowly increases in size. The next one. The next one. Yeah, thanks. The next one. Yeah, you got it in two. Thank you. It's coming. So very segmental syrinx. It was tense. This patient was in his 50s and presented with very severe interscapular. Thank you very much, Vijay. I'm finishing. So I'm finishing that. Normally, syrinx is with carry, post-traumatic, post-inflammatory, previous operation, blah, blah, blah. There was nothing in this. So we normally try to attempt to observe it. And if it increases, then go for the surgery. This can be very well treated by my Miss friends. I am Mr., so I'm sort of old-fashioned, but I know how to do endoscopy. So I'd love to see the endoscopy growing up. Last 4 decades in neurosurgery, myself and Dr. Parthiva and many of us. So this is that. And so you see the cyst? It's very tense. You see? I think the residents in the back seat can see, unless they're dozed off. Please don't doze off during a class. So that is the syrinx. And, as you also see that degenerative spine, so he also had some brachialgia. I said, hang on, your interscapular pain is very tense pain, non-dermatomal, dysesthetic, like spinal cord pain. So this is what I did, and I did a laminectomy, because sometimes, and there was a lot of, arachnoid additions. God knows whether he had. So what I did, I selected a small myelotomy, as you can see the hole, and then I wanted to put the thinnest tube inside, not to damage it. So thinnest available to me was, rather than a AVD catheter, was epidural catheter. That was the thinnest, and then I put it inside the cyst. But aspirated the cyst, made sure I was inside, but you can do with ultrasound guidance also. So that was a syringo-subarachnoid shunt. I did it after almost 28 years. One I did. So he did well. That pain went off. So friends, I just finish it in one line. If you have to drain a syrinx, if there is no other causes, and as I mentioned to you, no carry, so you can do a syringo-subarachnoid shunt. An interesting, small, little operation. Thank you very much for listening. Thank you. Sabit.
Thank you so much, sir. Can I have Dr. Satish Rudrappa next, please, for thoracic pedicle screws?
Good morning, everyone. As the spine surgery is growing, many of us now, in addition to the minimally invasive surgery, the deformity surgeries some of us do, where the thoracic pedicle screw insertion is the key in how. Pardon? No, I've given presentation. I've given, no? I know that naam tha. Right? Okay, I can give one laptop. Checked it. He checked, double checked actually. It's okay. Yeah. So the insertion of the thoracic pedicle screw is like cervical pedicle screw, especially in the upper thoracic region. It needs some amount of meticulousness. And unless you know how to do it, especially in the pediatric patients, you lose the anchors, which are very essential, especially when you are doing a deformity surgery. So look at this patient, those who attended yesterday's my presentation, I showed the same patient, a patient with a severe proximal thoracic as well as mid-thoracic kyphosis and scoliosis with significant deformity. And he was developing significant pain and also interscapular pains purely because of the progressive scoliosis which is happening for 2 to 3 years for him. He was just about 14 years at that time. And any of these things, we require the pedicle to correct it purely because pedicle gives a 3-column control to the vertebrae, and it is away from the spinal canal. So unless you go into the spinal canal can be manipulated by using the pedicle screw. And nowadays, with the use of the navigation and everything, the complex procedures are becoming simpler. We can make it. And there is a paradigm shift from the anterior to posterior approach because previously we used to do thoracotomy, drill the vertebrae and correct this procedure, but now everything can be done posterior approach alone. And it's among all the hooks, or if you take the sublaminar wires, the pedicle screw is the most stable construct which you can give, and you can do it for both short segment as well as long segments. And deformity corrections, it becomes very, very important in these patients. So knowing the anatomy is the key in this patient. As you see, the pedicle width in the thoracic region dips down completely at D5. It is very good at T1 and T2. The T4 and T5 is the smallest of all. In the size-wise from the, if you look at from the T1 to T12. In the transverse angulation also, there is a constant decrease from T1 to T12. And highest at T1 level, you had to go more medially, that is about 30 degrees. In cervical, at C4 level, you have to go almost about 45-degree angle. If you come to the thoracic, it will come to 30-degree angle. And if you go to D12, it is almost about 7-degree angle. At L1, we become almost about 5-degree angle. So from top to bottom, the angulation of the pedicle comes down from the cervical to lumbar region. Similarly, if you see the angulation in the sagittal plane, it is also gradually decreases from T2 to T12 level. At T2, it is almost about 19.2 degrees inferiorly to go. At T12, it is almost parallel to your end plate, is about just less than 10 degrees. So maintaining these 3 angles is a key in putting perfect pedicle screw. So in every patient, position changes because the problem in the thoracic region is its anatomy, and radiologically you will not get it because shoulder comes in its view. So at the level of, above T8, keep the arms next to the patient. Below T8, you can keep it like, patients with a prone position with a hand at the head level. So this positioning and keeping the C-arm is the key in these patients. And please use the digital, new C-arms or O-arm or Lupex, whatever you have, to do these procedures than just old conventional C-arms. So the conventional entry is the line bisecting the transverse process. With a vertical line, you do just medial to the lateral aspect of the pars intra-articularis. So that is the line in which we go it. At T9 to T12, you can see at T12 it's almost horizontal in an angulation from medial to lateral angle. And at T9, it is closer to almost about 17 degree. We are inferiorly directing. And in the conventional entry point, we always take a proximal edge of the transverse process. The proximal edge of the transverse process where it meets the superior facet. This is a point of entry. I will show you in my video. And you can see here, in some patient where the facet is sitting over that, you can remove the inferior facet using the small, the mallet, and take out these inferior facet so that superior facet and transverse process junction will be visible. And that is a point of entry, especially in the pediatric population. You will see, and patient with the Anky's pond, most of these things are completely fused. And when we do the ankylosing spondylosis patient for the kyphosis correction, removal of this facet is the key for the entry point. If the entry point is the key, angulation you can do based on the cancellous bone. And there are three types of methods we use. One is the straightforward method where you'll enter at the transverse process. There is a hump in the transverse process, directly enter the pedicle. The second one is the funnel technique. The funnel technique is very useful in the upper thoracic region and in the pediatric population. I will show you how to do the funnel technique. And the rescue technique is in-out-in technique. Means you enter at the transverse process at the in part and enter into the lateral part of the pedicle and then into the body where the medial border is completely preserved. This is only as a rescue technique. So I will show you one by one. If you see any transverse process in the upper region, this is the superior line of the transverse process. There is always a hump between the superior facet and the transverse, this hump. If you bite this hump, you'll find the cancerous bone with a bleeding coming. And that is the key in identifying. So it's usually slightly in an angle, and where the facet is completely fused, you have to remove the inferior facet. Otherwise, superior facet, you find the bottom of the superior facet, superior part of the transverse process, bite that part. As soon as you bite, usually in the normal bone, you'll find the bleeding coming from the cancellous bone. And then take the Lenke's probe. We use the Lenke's probe because it is an angle of about 6 to 7 degree medially rotated. So this is a tunnel technique. Once you make that cancellous bone, use the 1 mm upcut going medially to feel the medial border and the superior border. The key is understanding the medial, preserving the medial border and superior border. If you breach the lateral border, doesn't matter, you can re-enter. Medial border, it will enter the canal. So with 1 mm upcut, the foot of it, take out all the cancellous bone coming closer to you. You feel that the medial border and then put the Lenke's probe towards the medially, turning it laterally and go about 10 millimeter. At 10 millimeter is a pedicle, you're almost in the middle of the pedicle. So you can feel once again with the Lenke's probe, the medial border of it, take out all the cancellous bone, see under microscope or visually the cortical bone and then turn it medially to put it in. See, I'm turning it medially now and putting it into the body at that junction. Usually it is at 10 to 15 millimeter is at the pedicle level. After that, you will enter into the body. You will not make any mistake. So in the conventional direct method, we directly enter at the where I showed you the hump of the transverse process. So this is the caudal part, cranial. I'm doing on the left side. So mark that point, and you can bite it. Once you bite, you see the blood coming out, and use the probe just to feel, and never tap it or use the hammer. So, and don't use the force of the wrist. You had to wiggle it, and wiggling, enter into the cancerous bone without breaching it anywhere. So this is that funnel technique, where what I showed you.
take out the inferior part of 1/3 of the superior facet, inferior facet of the superior vertebrae to expose the superior facet of the place where we are entering the pedicle. So you can see the superior facet and transfer process junction is the another one. You can see the cancerous bone.
As soon as
so that is the
you find the bleeding coming there.
You enter with all.
With an all, just enter.
And enter in such a way that you just make a hole. The angle of the the facet with the length is go, which is an angle. To start with, go inside. We call it as tunneling technique. The tunneling technique involves you put into the hole you made, feel the medial wall. Feel the medial wall. So enter in such a way that you feel the medial wall. Here, I am feeling the medial wall.
So take out all the cortical bone from the superior part till you feel the medial border and the superior border.
Can be seen.
And take the X-rays. If you see there, as soon as I'm just making, it is almost at the medial, middle of the pedicle. And as you go laterally, it will become, we are almost into that, and everything is done with a wiggling of the hand, and don't use any force. So in that way, you can definitely make the palpatory method is the best method in this, whenever you are doing it. And in a patient with, whenever you lose the pedicle, in-out technique you can do, where you have to enter laterally at the rib head, enter into the transverse process, into the rib head, and enter to the body. And it will be very, very useful as a rescue technique. And in pediatric population, use the K-wire technique, put the K-wire into that so that the direction will not go haywire, and over that cannulated screw should be used. Otherwise, in especially congenital scoliosis and early onset scoliosis, there will not be cancerous bone in the pedicle. There is only with a blunt probe we use it. We have to expand that with pedicle screw itself. And with a navigation, all these things are becoming much more better, and you will have a better control of these patients. So in this way, in this patient where there is an anatomy is completely haywire, we can use the technique and use either the cannulated technique or the in-out technique. Every pedicle screw, especially at the apex, proximal UIV, that is upper anchor, and the lower anchor has to be fixed properly to have a good outcome in these patients. So essential is good lupex you can use, or good O-arm and navigation technique in these patients. So main thing is understanding the key anatomy, good imaging and positioning, and you have to feel intraosseous feeling is important. Navigation guided complex cases can be used, and be careful when you use the pediatric patients. Thank you very much.
Thank you so much, sir. Can I invite Dr. Narsingh Rao to speak on posterior cervical laminoforaminotomy?
Good morning, everyone. And from Satish Rudrapa's complex presentation of scoliotic surgery to my simple technique of cervical laminoforaminotomy. All 3 days, it's a fantastic conference. Congratulations to Dr. Manas and Dr. Savit Shastri for organizing a conference which has academics, great food, and entertainment, all jam-packed together. I really enjoyed the conference. Yesterday, of course, it was raining. I could not make it to the dinner, but I'm sure every one of us are enjoying the meeting. I really like the slide by Dr. A.K. Purohit, in which he took out the India and put it as Bharat, and just copying the same thing here. So I'm working as a consultant in Yashoda, Now, the cervicolaminoforaminotomy is an age-old technique which every one of us are aware. But in residency, what happens is most of the times the anterior cervical approaches is more commonly done than posterior approach. So just highlighting the importance of anatomy and highlighting the technical nuances of this procedure. So the neck pain we all know is the fourth leading cause of disability, and cervical disc as a pathology is the most common neurosurgical practice we encounter these cases. But important as the clinical neurology goes is that you should know that the pain is coming from the cervical disc. That is the first thing which I want to emphasize. Then only our procedure will be successful. We all know the anterior cervical approaches and posterior cervical approaches. Laminoforaminotomy is a simple technique. This is, I would say, just an extension of laminectomy, but it is taking out the disc as in lumbar, which we are all familiar with, extending the same technique to the cervical. That is what is the technique is about. A brief interesting point is that it took 10 years for the surgeons to really make the cervical laminoforaminotomy to discover following the lumbar discectomy. That shows the hesitancy of it. Scovielli and Whitcomb actually popularized this procedure. So coming to the anatomical details, we all know that the cervical foramina, as in lumbar phenomena, is bounded by the facets, joints, posteriorly. Anteriorly, we have the lateralmost part of the vertebral body and the disc space. So it has got I'm sure this is not to be displayed, but anyway, you have the superiorly the pedicle, and inferiorly the pedicle, and along with the vertebral artery, and posteriorly you have facet joint, and anteriorly the lateralmost part of the vertebral bodies. So there are three areas. One is the entry point where there is an orifice for the intervertebral foramina, and a narrow intermediate area which you have to drill to make it widen. And then there is a lateral area in which the spinal nerves, they exit out of the neural foramina. So what we have to understand is that the 30 to 50% is occupied by the neural structures. The rest is by the vessels. So you have radicular arteries and also veins coming in way for the during the dissection. And more important to note that the posterior root, you have an anterior root and a posterior root, and posterior root is 3 times larger than the anterior root. So the basic differences we know: cervical disc, which involve only one root, and lumbar, you can have involvement of both the roots of exiting as well as the traversing nerve roots. So why laminoforaminotomy? Laminoforaminotomy mainly takes away the fusion which is required for anterocervical discectomy if you are doing. So there is no spinal fusion which is required, and of course it's a quick and immediate pain relief is observed, and the inherent procedural complications like the cervical, the anterocervical discectomy, the esophageal injuries, and the carotid artery injuries are can be avoided by doing this approach. It's a simple and a direct approach. And I want to stress here that the vertebral artery is not at all coming in the picture. So you can be relatively safe and perform this procedure. So younger patient, I have put it as below 60 years here, because if it is a soft disc in the younger age group of below 50 and 60, it can be done with no significant spondylosis. Of course, contraindications if you have, apart from the disc, if you have an osteophyte, I think this is not the very good procedure to do. Just to get an overview of this thing, it play. So just to get the overview, this is a video which is copied from the YouTube. It's not my own. And you just have to drill the inferior portion of the lamina, superior lamina, and the facet of both the superior articular facet as well as the inferior articular facet, and widen the neural foramina and take out the disc. This is what we are going to do. So how safe? It is a safe procedure. Up to 70 to 96% of the radicular pains are described, relief of radicular symptoms are described in the literature. No revision surgeries and no CSF leaks, provided you do it correctly. So this is a review article which shows that the posterior laminotomy is a safe procedure. Some of the articles which I have just added here. So what all the tools need? You need to localize the level of the surgery with a C-arm, and high-speed drills, and a diamond drill is required. Of course, you need a good high-end microscope to visualize the anatomy. Want to highlight that endoscopic procedures now it has common. The same thing is done in the endoscope, but I feel microscope is best, which we all neurosurgeons in the NSSA, only neurosurgeons as I see. So most of us are familiar with the microscope, and we can do this procedure fantastically with this. Yeah, this is a classic cervical disc presentation with a spiraling sign out there. So this is a C6-7 disc, big disc, as an operative video. The skin incision is midline, around 2 inches, because it all depends on what kind of retractor you have. If you have a small retractor, you can reduce the even the incisional space. This is the C6, 7. This is superior and inferior. C6 is above and C7 is below. So you start drilling the facet joints, C6. You should go line by line, as previous speakers have also identified the cortical bone, cancellous bone, and the cortical bone you have to identify. And once you drill off the C6 totally, you go down to the superior articular process of the C7. And once you expose it, you find the ligamentum flavum, which you have to hold with a hook and cut it, not to injure the dura over the spinal. And you should achieve a clear-cut hemostasis by using bone wax and coagulating. This is called trilar drilling. This is a very important concept. You have to identify the root and the dural sleeve. I mean, the dura covering the card as well as the root you have to identify before you incise the disc. So this is the stretched out disc as I highlighted here and labeled. So this is how you have to open the PLL over the stretched out disc. Of course, in this case, the disc was huge, so disc is actually pointing it out. And once you totally cut the PLL over the disc space, you can use a hook. I found this instrument is most crucial in these surgeries because your exposure is less. You don't need more exposure in this case. So you can take out the disc fantastically like this because, of course, this is a big disc. Every neurosurgeon wants to do disc like this. We are happy at the end of this procedure. Relaxed root, you can see. Whatever residual disc is there, you can take out with a beautiful micro disc ronger. Of course, I am not having that, so I had to struggle with the dirty disc ronger which is given. So I'm sure these are essential tools which I wanted to highlight, that you should need a micro discectomy forceps, put some fat over there, and then the procedure is done. So you have a happy post-op patient if you have done the job correctly. This is another small video. Yeah, it's playing. This is also another C6-7 disc. This is a patient was a little obese. You have put it in the prone position with the C6-7 identification with the C-arm. Sometimes you find the difficulty with the C-arm and C6-7 because the C6-7 is not exposed in obese patients. These patients, what I'm showing, it's a little different from the previous one because I had to take the disc from the shoulder of the disc, not from the axilla, which in the previous case which I showed. So again, the same procedure stuff, drilling of the C6 facet, and then the C7 facet. This is the superior and this is inferior. This is the midline. This side is midline and lateral is the opposite side. Always you should do this procedure from the contralateral side. Suppose you have a right side disc, you should approach from the left side. And if you have a left side, you should go to the opposite side of the patient because the microscope, angulations and all become difficult and drilling also becomes easy if you can do it from the contralateral side. So trilar drilling, as I showed in the previous video. Here I just want to highlight that you should know where exactly is the disc. Then only you can trilar drill that particular portion with a diamond drill. This comes out, of course, with a little understanding of the anatomy and visualization of anatomy in your mind. So here I can show that this is the root and this is the dural sleeve. So unless you identify the dural sleeve and the root, you should not be approaching or trying to open the disc at all. So this is where I'm cutting. As you can see, I am above the I'm towards the head of the patient because on the shoulder of the root, as you can find, again you have the use of the hook technique. And once you use the hook, even the disc material which is lying underneath the root which is getting stretched will come off. Of course, you can have a little more widening of the space, but not really required. So you have again epidural venous bleeding coming so as to be happy with the patient, of course, post-op. So it's a safe and effective procedure. Case selection is important, and needless to mention, experience and expertise and three-dimensional orientation of the anatomy is important for this. Thank you. Thank you for your attention.
Thank you, sir. Our next speaker is Dr. Chandan Mahanti. One of the problems with having speakers as your friends is they ask you to present on spinal AV fistulas when you ask them to present on extraforaminal disc. And in the last moment, they choose to present on extraforaminal discectomy instead of what they asked for. So Chandan is not speaking on spinal AVF. He is speaking on tubular microdiscectomy for far lateral discs.
Thanks for the
kind introduction, Dr. Savit, and thank you for Dr. Manas sir for the kind invitation. So we'll go to, from posterior cervical, we'll go to now for far lateral disc, tubular microdiscectomy. So far lateral disc generally is considered to be slightly more rare compared to your conventional lumbar discs. And it has a lot of different nomenclatures. If you look in the literature, it's sometimes called as extreme lateral, far lateral, extra canalicular, or extra foraminal disc. So searching for papers is also somewhat of a challenge when you look for this condition. So it affects about 2 to 12%, so very low frequency compared to your routine lumbar discs. And it happens more frequently in the upper lumbar spine. So that is an important distinction where the routine lumbar disc herniation is in the L4, L4-5 and the L5-S1, where you have the maximum axial load. The far lateral discs happen in the upper lumbar spine, and they happen more commonly in the elderly than in the young. And more frequently than not, they are sequestered in nature. So the nerve root is typically moved more superiorly or sometimes even posteriorly by the disc herniation. So when you look for the tubular approach to the far lateral disc, it is not through the multifidus muscle, it's actually just lateral to the multifidus muscle. It's basically, if you follow the natural septae between the multifidus and the longissimus muscle, which is marked here, that is the place that will take you to the far lateral disc. And once you see the video, you will realize that, in fact, it's a much easier surgery than the routine lumbar discectomy, because your bony removal is almost negligible. So there are two techniques of far lateral disc. So one is the classical technique where the docking happens at the junction of the transverse process and the pars. So you are basically docking in the upper part of the foramen, and the root is slightly inferior. So you will see the root in the inferior quadrant of your tube. And the second docking happens, which is described again, is at the junction of the facet joint and the transverse process. So the first docking is at the level of the pars and transverse process, and the second one is at the facet and the transverse process. So usually, and that the view and the smaller pictures down is what it shows, the view that you will identify the root. So the modified technique is the one which I prefer personally, where you dock on the transverse process inferiorly, and you see the root in the upper quadrant of your tube. So this is this is a 50-year-old male, and he had an acute low back pain radiating to the left knee of 10 days duration, severe antalgic gait, and limping, and no neurodeficits, which usually is the case. So you have to remember that the sagittal view is barely going to show you anything, and more often than not, these disc herniations are missed if you just look at the sagittal views. So the view to look at is actually the parasagittal cuts, where you look at the foramen. So the foramen, if you can see here, it looks like a keyhole with the root at the top. So that is one major distinction between a cervical foramen and a lumbar foramen. In the lumbar foramen, the root is in the upper half, whereas in the cervical foramen, the root is in the lower half, as showed by Nursing Rao sir. So we have to identify the disc here in the parasagittal cuts, where you see that the keyhole foramen is completely obliterated. And then on axial, once you identify here on axial, then it becomes much easier. So the left half is the, sorry. So the left half is the cranial, and the lower part is the caudal. This is the medial, and this is the lateral. So we have docked between the two transverse processes, and the first step was to take a small bite from the transverse process, the inferior transverse process, and you basically identify the intertransverse ligament, which we are now picking it up with a ball hook. So the bone dissection is only as much to release the intertransverse ligament. You don't really need to do much bony work at all. The main thing is you have to make sure that you identify the root which will be right under
the intertransverse ligament. That's the root. So without removing any bone, you have directly landed on your target, which is the intertransverse ligament, and right underneath is the root. And you have to remember that you have the ganglion right there. So the important thing is not to have a constant root retractor during surgery. You need to have a dynamic retractor, which is always the suction in your left hand. And you can see that the adhesions between the root and the disc here in this case, it's not easy to mobilize it in the beginning. So if it's not easy to mobilize in the beginning, you might have to take a little bit of the transverse process, and even a little bit of lateral facetectomy may be required if the disc herniation is more in the foramen rather than the extraforamen region. So here now you see that we have been able to push the root away, and the annulus is being cut, and you see the disc popping out from there. And the next steps are again the routine steps where you basically go in, fish out all the pieces of disc herniation, and then achieve a good root decompression. So we'll take out the disc through microdisc forceps. So again, very important point, not to use a constant retractor, not to have an assistant retracting the root. I think that causes a neuropathic pain complex, which can sometimes be very, very tough to treat. I have had a patient who, even with using this technique, has had a neuropathic pain post-op, which lasted for about 3 to 4 weeks after the surgery. Following which she was absolutely fine. The radicular pain went away, but she had this severe dysesthetic pain, which was taken care over a period of time. So then you get the disc fragment out. So the only problem with this is sometimes it's difficult to approach the L5-S1 level. So for example, here you can see the L5-S1 level is slightly difficult to approach with this, especially if you have a thick iliac crests which are obstructing that path. So in that case, you can use something called as a transalar modification, so which basically entails drilling through the ala. So you can see the patient here had a large osteophyte with a soft disc here, which was both excised laterally. And you can see all the bony anatomy is left intact, right? And all the muscles of the back, which is the multifidus muscle and the longus muscle, you can see none of the anatomical architecture is disturbed. So that's again the major advantage of a tubular approach. So my take-home message is that diagnosis is important based on clinical, parietal, and axial MRI. You look at the height of the crest if you're dealing at the L5-S1 level. Do minimum handling of the root and the dorsal root ganglion. The root has to be retracted superiorly and laterally, which is contrary to how you retract the root in a routine lumbar case. Get a good hemostasis. The patient will always thank you for this. And thank you very much to Dr. Rakesh Lohana for providing the case. Thank you.
Thank you, Dr. Chandan. Up next, we have Dr. Ramesh Chandra. He's going to talk to us about the OLIF. He was right here. Akshay, are you ready? I think he stepped out for coffee. We have Dr. Akshay Hari, who's going to show us how to put in a percutaneous pedicle screw.
Yeah, sorry. Okay, no problem. No audio. Hello everyone, I'm Dr. Akshay. I'm going to be talking about percutaneous pedicle screw fixation. So first I'll be talking about the fluoroscopic guided percutaneous pedicle screw fixation, how we do it. These are the 10 key technical steps, right from the positioning all the way up to the screw placement and rod insertion. So I'll be talking about all these steps in detail. So coming to the positioning, so patient should always be positioned prone and on a radiolucent table in such a way that the true AP and lateral fluoroscopic images are taken. So the true AP is one where the spinous process is exactly in midline between the two pedicles, and the true lateral is where the end plates are parallel and not elliptical, and the pedicles are aligned equally. Subsequently, once we have the true AP image, we should mark the midline and the lateral pedicular lines on both the sides. So using these lines as the references, we use them to mark the skin incision. So using needles, we direct needles which are pointing towards the pedicles in both the AP and the lateral images, and the skin incision is marked between these two needles. The next step is the pedicle docking. So we should remember the anatomical landmarks, how the pedicle is to be docked between at the junction of the transverse process and the facet joint, and the skin incision is taken up appropriately. Then the pedicle, the jump shade needle is then, using a jump shade needle, we advance the pedicle. And we should remember that an important point to be noted is that the pedicle should not be, the jump shade needle should not be advanced in the true AP image. It should not be advanced beyond the medial border of the pedicle until we do a lateral image where we are seeing that the jump shade needle is already into the vertebral body. So, and also we should, the starting point for the pedicle entry is at the 2 o'clock position or the 8 o'clock or the 10 o'clock position on the right and the left, for the right and the left pedicles in the AP image. So this is what you should remember, that once you are reaching the medial border, we should take a lateral X-ray to see whether the jump shade needle has crossed the pedicle or not. Then the guide wire is placed. So another important point to be noted is when the guide wire is being placed, somebody should be holding the assistant. It should be very important that assistant holds the guide wire in place while the jump shade needle is being removed to prevent inadvertent removal of the guide wire. And then the guide wire is then secured. At this point, we take an AP and a lateral images, because beyond that, we cannot, if any correction is needed, it can be done at that point itself. Then the next step is the sequential dilators. So this is to dilate the skin, the muscle and the fascia so that it doesn't come in the way of the screw placement. So the pedicle, using a tap, appropriate tap, which can be either 4 millimeters or 5 millimeters, depending on the pedicle required size. The tapping is done. At this point, once again, we should remember that the guide wire should always be within the body and to prevent inadvertent removal. In case the guide wire, the tap is advanced beyond the guide wire, sometimes we can use what you just saw, we can use a hammer or mallet to just tap the guide wire so that it is not removed while the tap is being removed. And once again, we take images to make sure that the guide wire is in place. So because that is the very most important step, because everything is based on the guide wire. Then subsequently, screws can be placed over the guide wire. And once the screw is advanced beyond the pedicle, the guide wire can be removed. So these are the various percutaneous screw systems which are available. So you can see the Medtronic, and the Medtronic has a longitude and sextant system where there are towers which are attached to the screws, whereas the other systems have screw extenders or towers which can be extended beyond the skin. So yeah, this is the sextant system which is being shown over here. So this, using the similar steps, all the other pedicles which are required to be the screws to be placed are also done. Then we come to the rod insertion. An appropriate size rod is taken based on the rod measuring device. And then the rod assembly is then used. This is a sextant arc, and the rod is inserted. So in this system, the rod goes directly into the screw tulips. And then the screw caps are tightened. This is the break of plugs which are being inserted. And then compression can be done if required. And the screw caps are then broken off. And then the entire hardware assembly can be disassembled. So there are various rod entry methods. One is what you just saw is the arc-based entry, which is usually having a fixed angle lordotic rod, and this can be used for 1 or 2 levels. Then there are other systems which are using through these extended towers or the free handheld entry. This can be used for multiple levels, and even using rods can be kyphotic or lordotic in such cases. Using similar steps, whatever I have just described, the contralateral side is also tapped, and the guide wire is placed, and subsequently tapping is done, and the screws are also inserted. These are the same steps what I have already described. And as you can see, the guide wire, once the screw is advanced beyond the pedicle, the guide wire can be removed. These are the steps for sequential dilatation. At every point, we should make sure that, like I already mentioned, the guide wire should be kept in place to prevent inadvertent misplacement of the screw. This is the final AP and the lateral images. You can see that the screws. So the next, what I'm going to talk about is the 3D OAM or second generation navigation guided screw placement. So once again, patient is positioned prone on a radiolucent table. Here, the first step is the placement of the reference frame or a percutaneous pin on the PSIS. So this we are seeing the OAM, which is using the OAM. The patient is draped completely, and so the patient is completely draped, and what we are seeing is only the reference frame which is exposed, and then the OAM image acquisition is taken. So this is how the images that we get. We get images in all 3 planes, sagittal, coronal, as well as an axial. So using these images, we first mark the skin incision. So what we are seeing here is the reference probe, navigation probe, using that. So we have a virtual projection which is created, and the trajectory for the pedicle entry is marked. And using that, we mark the skin incision. So there is no C-arm or any fluoroscopy which is taken at this point of time. Then using the navigation guided gem-shaped needle or pedicle access kit, what we can see, the pedicle is, the gem-shaped needle is docked. So you can see in all 3 planes, AP, lateral, as well as the sagittal and axial planes, you can make sure that the docking is done at the anatomical landmarks, and the pedicle can be, the needle can be advanced into the pedicle. And once a sufficient length has been advanced, the guide wire is then inserted. So at this step, we can make sure in all 3 planes, we will know what kind of a screw, the screw length, as well as the breadth, as well as the depth, everything can be gauged at this point itself. And appropriate screw can be determined. Then the guide wire is placed similar to how it was placed in the fluoroscopy guided. So what I'm showing here is that how we can save time by simultaneously 2 surgeons working at the same time, since there is no C-arm that is there in between. And while one person is placing the pedicle screw on the gem-shaped needle on the pedicle on one side, the other side another surgeon can be doing at the same time. And at any point of time, the probe with the is facing the navigation. One of them is facing the other, while the other at the same time the other one can be directed away from the camera. So at any point of time, one of the gem-shaped needles will be facing the camera. The next steps, as I already explained, the sequential dilatation. And even here, the tap can be projected. A virtual projection of the tap can be created, and we can make sure where the tap is going. The only thing that we need to make sure is that the guide wire at this stage is not navigable. So while removing the tap, it can be useful to measure, to take C-arm shots at this stage to make sure that the guide wire is not inadvertently removed, as you can see over here. So subsequently, in all the pedicles, the tapping is done and the screw placement is made. So even the screw can be projected. A virtual projection of the screw can be created. And in the systems which are not compatible with navigation as well, we can create what we are seeing here is a virtual projection of the screw by attaching a reference frame onto the screwdriver, whichever is, and then once that is done, the entire screwdriver assembly can become navigable. Then the guide wire is removed, and the subsequent screws can be placed for all the pedicles which are required. C-arm shots can be taken because if you want to just confirm. So the only step at this stage which is not navigable is the placement of the rod. So this is the assembly which is through the extended towers. That is a longitude system, and this needs to be done under C-arm guidance only. And as you can see here, all the screws, tapping, everything is done. and this is the final. So at the final, at the end, we can always, since we have an O-arm, we can always do a final post-operative O-arm check as well. Thank you.
Thank you so much, Dr. Akshay. Fantastic presentation. Can we have Dr. Ramesh Chandra up next? He usually comes to conferences with laddus from Tirupati, but due to recent controversies, he decided not to do that this time. He will be talking to us about OLIF.
I would like to thank Dr. Manas and Dr. Savitra for having me here. Laptop. Okay. I will be presenting on oblique lumbar interbody fusion or anterior to the psoas approach. So, basic anatomy. So we have so many minimally invasive approaches for spondylolisthesis. So the anterior approaches or the lateral approaches, we have DLIF for the direct lateral approach, OLIF and the mini ALIF. So here in our anterior to the psoas approach, so this is the MRI taken in lateral position. So we use this corridor between the psoas and the greater vessels. So usually the left side up, because managing the arteries is easier than the vein. So usually, traditionally the position is lateral position with the left side up. So this is the psoas muscle and this is the great vessel. So this is the corridor which we use for the approach. So it's called the anterior to the psoas approach or the oblique lumbar interbody fusion. So both radiologically and cadaveric studies have shown that there is a corridor. This is the greater vessel and this is the anterior border of the psoas, between ranging from around you can say 10 to 16 depending upon the 10 to 16 mm depending upon the level of the approach we do. So traditionally L2 to L5 we can do OLIF, and L5-1 you need to, though we can do an OLIF through the lateral approach or we can do an ALIF through the supine position. And there is another thing like how you do in an ACDF where the longus coeli is retracted a little bit. If you can retract the anterior border of the psoas a little bit, you can undermine the anterior border of the psoas. Usually the anterior border doesn't contain any neural plexus. There the corridor can be increased exponentially. So this is the anatomical part of it. And now all these lateral and anterior approaches depend upon what is known as an indirect decompression. So here you can see this is the level of the listhesis, and you can see the ligamentum flavum being buckled. So basically, this is not an hypertrophy. This is the buckling of the ligamentum flavum because the disc space is decreased. So once you distract it with an anterior or the lateral cage, you get the ligamentum flavum become straightened. So here there was no other posterior approach being done. So all these approaches depend upon the concept of indirect decompression. So recovery of the disc height, so there occurs what is known as the ligamentotaxis of the ligamentum flavum and the PLL, and direction of slippage. And because the foot plate of the cage is huge, so you get coronally asymmetrical disc spaces also correct automatically. The main thing, the prerequisite, the limiting factor for OLIF is your corridor. So we analyzed around 100 patients of spondylolisthesis. We excluded all lumbarization and sacralization. And what we found was approximately 22% of the people won't have this corridor. So you can see here, this is the corridor. This is the very ideal corridor, ideal case for a beginners to start with, where the psoas just abruptly ends here. But here there is a slight the corridor is a little bit deeper. Here again deeper. Here is a Mickey Mouse type of psoas where it is well difficult, and we correlated prospectively with the time to dock. So as the grade of the olive corridor increases, difficulty increases, the time to dock increases, as well as the tissue injury markers. And this is the type 4 where in the corridor only you have the great vessels and some veins, so where vascular structures are there, where olive is not advisable. Now another thing, normal structures. What you encounter in olive? So there are basic structures, the psoas, and in L4-5 you can get the genitofemoral nerve coming like this, the disc space, and the lumbar sympathetic tract. So the approach is basically, all the general surgeons will be familiar with, that is the lumbar sympathectomy approach, where you directly go to the through the flank and then reach the lumbar sympathectomy to do the lumbar sympathectomy. It's the same thing. These are the structures where you find. A closer view here, the psoas, there's the anterior border, you have the genitofemoral nerve and the lumbar sympathetic tract. And sometimes you may encounter the ureter. So usually when you sweep the retroperitoneal structures, the ureter comes with the retroperitoneal structures, but sometimes you can encounter the ureter where you can just resect it off. And another thing, iliolumbar vein. So here is L4 and L5. So iliolumbar vein moves across the L5 vertebra. So we don't put a pin here to secure the retractor. So retractor has 2 slots to put a pin. So preferably we put a pin in the L4 vertebra so that we don't put a pin there, because we may injure the iliolumbar vein. So this is the setup. So a microscope, good imaging system, the retractor, the cage, and the patient. And now I have shifted to exoscope, because managing the microscope and CM at the same time becomes difficult even with the good positioning. So exoscope is better in olive. The workflow, so positioning, then midpoint of the disc, this is the incision marking, placement of the retractor, disc preparation, breaking of the annulus, that's a very important thing, then trial, putting the cage, and then the posterior fixation. So positioning, so this is the lateral position. We need to strap the patient at 3 points, the chest, the hip, and the knee, and no table break, as you see in the director approaches. Now, because we put the hip in extended position so that the psoas muscle becomes tight. So this won't increase the corridor, but this will help you while doing the surgery, wherein you can nicely feel the taut psoas, and it will guide you toward the anterior part of the psoas. Now, first thing, you mark the disc. So this square part indicates the L4-5 disc here, and midpoint of the disc. So you mark the midpoint of the disc, and 5 to 10 centimeters anywhere you can do a incision. So the incision can be longitudinal like this. It can be horizontal or vertical. So if you want to do 2 levels, then directly point against the body, L4 body. Or if you want to do in a single level, it is like this. And again, my preference depends upon the bulk of the patient also. If the patient is very bulky, I prefer to put an incision like this so that my finger can move down across the psoas. If it is like this, then the skin incision will hit my finger, and I won't be able to go there. And if it is a very thin patient, even horizontal incision works well. Now the dissection. So this is what in the lateral position. So first thing is you split the muscles here. So very minimal amount you cut. So you split the muscles, external oblique, internal oblique, and transverse abdominis. Then once you roll your finger underneath, you move your finger underneath the anterior abdominal to reach the quadratus lumborum. This is the quadratus lumborum muscle. Then sweep your finger on the quadratus lumborum to reach the TP. This is a transverse process. Then you roll your finger across the psoas to reach the anterior border of the psoas. So basically, if you see here, only the retroperitoneum is the structure and the anterior abdominal wall is the structure. Everything, because of the gravity, falls away from your this thing. So directly you can place a retractor. The initial phase we use to the retractors which we borrow from the urology OT. These are very helpful to do the initial part. One maneuver which is very important in olive is orthogonal maneuver. So this is one concept which everyone should know before attempting olive, because see, the entry is like this, but the instrumentation is like this. So though you enter the corridor like this, you have to do the ultimate instrumentation, cage placement, discectomy, breaking the annulus, everything in this way. So for that, we should make sure that the retractor opens up near the disc. So this is the opening in the retractor, and this is the disc space. So this is what we call the orthogonal maneuver. All the instrumentation should be done outside the retractor. So the approach is like this, but your instrumentation should be in the perpendicular to the disc space. This is one concept, because if you don't do this, you can directly enter into the canal. And disc preparation, according to Richard Hines, who introduced this tube-based lift, this is the anterior 2/5 is the ideal place where you need to dock. So this is what I was explaining. If you don't do the orthogonal maneuver, you will end up into the posterior part. If you do an orthogonal maneuver, you will be in the center. And another thing is disc preparation. That should be very accurate. Good clearance of the disc, especially the blind spots under the psoas and the anterior part. And aggressive end plate preparation should be avoided. So most common complication in the initial stages is subsidence. So you should prevent this aggressive end plate preparation and over distraction. Those two things should be prevented. And compress relief of the annulus should be done. And I prefer doing it with a hand so that I get the tactile feedback. And cage positioning depends upon the initial docking point, good disc clearance, complete release of the annulus, and good orthogonal maneuver. And preferred cage position is, if you are correcting an deformity, it's on the anterior space. If you are doing it for a foraminal stenosis, it will be in the mid or posterior. So this again, this orthogonal maneuver, this is how we do an orthogonal maneuver. So you start entering the disc anteriorly, but the moment you go, you should go like this. And again, there should not be any rotation while you do this. So I finish it with a 2-minute video. So this is the skin incision. Only two things you cut: the skin, subcutaneous tissue, and the fascia or the external oblique. This is the external oblique. This is the fascia or the external oblique. You split the external oblique. This is the internal oblique. You can see the fibers, how they are oriented. This is the external, this is the internal oblique. Moment you trim the internal oblique, you can see the transverse abdominis. Now the retroperitoneum with the transverse fascia is, you can see the structure here. This is the retroperitoneum with the slide. Then you, with the finger dissection and the Kittner, you simply bring down the retroperitoneum down and expose the psoas and come forward. This is the anterior border of the psoas here, the genitofemoral nerve and the lumbar sympathetic tract. That you can be mobilized with dissection. I prefer to do with the dilator, first dilator or the dissector, so that the disc is exposed. Anterior border of psoas little bit also can be retracted like longus colli muscle, and then here you find the disc here. Then you put the retractor system. The first dilator, second dilator, the final third dilator, then the final retractor. Then fix it with the pin. So if it's L4-5, I prefer to fix only here. Then you open up. So while opening up, you should make sure that this opening is in line with your disc, so that your disc work is done without getting hampered. So then everything is like the normal routine: discectomies, disc preparation, end plate preparation, scrapers, curettes. And this is the COBS where this is the orthogonal maneuver. You go that side and break the opposite annulus. This is the trial. So anterior is lordotic. And this is the cage. The beauty of this procedure is everything falls back. So there is nothing to do. This is the retroperitoneum falling back. You have the transverse abdominis coming next. You have the internal oblique and the external oblique. So depending upon your initial cases should be simple cases. You can then move on to degenerative scoliosis. So pre-op planning, thorough knowledge of anatomy, perfect positioning, retractor alignment, appropriate docking, good disc clearance, and a good orthogonal maneuver will give you a good cage positioning for a successful ATP procedure. Thank you.
Thank you, sir. I want to say Laddu presentation, but can I have Dr. Rakshit up next, who will show us a minimally invasive excision of an intradural extramedullary tumor.
So you can you give the full screen, because I can't, I have to rush in the, go forward in the Good afternoon, everyone. At the outset, I would like to thank Dr. Manas and Dr. Savitra for having given me this opportunity. Today, I'd be presenting on MISS IDEM, how I do it. So this is a 48-year-old female patient presented to us with low backache since the last 4 months, occasionally radiating to the left lower limb in the posterior lateral aspect. There was no history of weakness, sensory loss, bladder disturbances, and on examination, there was no neurocutaneous markers and no neurological deficits. The MRI-LS spine, this is a T2-weighted sagittal section, shows a heterogeneous isointense lesion at the level of L4. MRI with GAD shows a well-circumscribed enhancing lesion at the level of L4. This is an axial MRI with GAD showing a well-circumscribed, centrally located enhancing lesion at L4. So we decided to go ahead and do a MIS tubular excision of this tumor. The video is not playing.
We are going to monitor MEP and SSAP.
We
so
use
the sampling
neuromonitoring.
electrodes are connected to the rectus abdominis muscle, quadriceps muscle, tibialis anterior, AHL and AHL. It's bilateral sampling, and we have connected for the tibialis anterior for SSAP lower limb monitoring, and median nerve for the upper limb monitoring. And our recording electrodes for SSAP and MEP are connected to the scalp.
Okay, the patient is positioned prone on rolls. Care is taken to protect all the bony prominences. He's positioned on a head frame, and we can clearly see that the eye is well protected and there is no pressure on the eyeballs. All bony prominences are made sure there is no pressure, and once we will also be placing a pneumatic compression stocking on his lower limbs. And these are the leads that have been placed, including the anal sphincter. So the marking is done 1 centimeter from the midline and confirmed with a needle on fluoroscopy. This is a 1.8 centimeter incision, about 1 centimeter lateral to the midline. Once the skin incision is made, at the same line, the fascia is cut linearly. Once the fascia is cut, the first dilator is passed. You feel the lamina, toggle the dilator cranially, caudally, medially and laterally, trace the lamina laterally and dock at the laminofacetal junction. Confirmed position on CM. So the next dilator is passed over the first dilator. Again, craniocaudal toggle, mediolateral toggle, and then land at the lumbar. So serial dilators are placed in the similar fashion, and then a final tube was selected, which was 18 millimeters in size and 4 millimeters in length. Before fixing it to the table fixator, the position is confirmed again on fluoroscopy. So this is the final positioning of the tube.
We will have to drill this much of the
We have
L4
sufficient
lamina.
space to drill the lamina, and there's good medial angulation to do almost an over-the-top decompression. So the some amount of muscles which are there is being removed. 12 o'clock is the cranial position, 3 o'clock is medial, 6 o'clock is caudal, and 9 o'clock is lateral. So once the anatomy is clear, the lamino-facet junction, the spino-laminar junction is well exposed, and then the drilling is started. I use a Medtronic drill with a matchstick drill bit, which prevents any injury to the underlying dura as we go to the upper level of the lamina, where there is no ligamentum flavum to protect the dura. So the drilling is performed, and once the drilling is complete, the ligamentum flavum is carefully dissected and removed. So once the ligamentum flavum is removed, you can see there is a nice decompression and adequate space to open the dura in the midline, and using a dissector, carefully the pia is separated and the dura is opened with micro scissors. So this is the dural opening that is being extended, just adequate for tumor removal, and also we need to have space for closure. So it should not be open till the edges of the tubes. So once the dura is removed, tacking proline sutures are taken. And the tumor is right under vision. The tumor capsule is coagulated, and tumor decompression is started with scissors. So before making an incision on the capsule, the monopolar neuromonitoring probe can be used to stimulate and to confirm that there is no nerve attached on the capsule posteriorly. Care is taken to gently push the nerve roots on either side, medially and laterally, and micropatties can be used to make sure that the nerve roots do not come into the field. So this decompression can also be done using a CUSA, if you have a pencil tip fine CUSA. So this is the final part of the tumor that is being excised. The tumor is being shaved off the single nerve root from where it is arising. Hemostasis is achieved, and the dura can be closed with a 6O proline, preferably with a 9 millimeter needle, because the space there is very limited, and the bayonet-shaped knot pusher is a very useful instrument when you're doing suturing with a tube. So around 3 to 4 Prolene sutures have been placed. We can also use Liga clips if you're comfortable with that. And finally, a piece of Duragen is placed over that. So as the tubes are removed, hemostasis is achieved. So this is the size of the incision. The histopathology was a schwannoma. It was a recently performed surgery, so I do not have the post-operative images. Thank you.
Thank you so much, Dr. Rakshit. Can we have Dr. Rakesh Lohana up next, who's going to speak about endoscopic cervical laminar foraminotomy?
Good afternoon, everyone. So my talk is on full endoscopic monoportal posterior cervical laminoforaminotomy. We had similar talk on open cervical laminoforaminotomy. So it's the same thing, but using through 9mm scope. So sharing a case, cervical radiculopathy with triceps weakness, unresponsive to medical management, and the MRI showed C6-7 foraminal disc. C6-7 acute foraminal disc. This is a classical case where you would go for posterior cervical laminoforaminotomy. You get X-ray under general anesthesia. The position is prone. Here you have to use AP view, so better you use this kind of headrest rather than horseshoe or clamp. And then docking is done under mark your incision in AP view, identify medial pedicular line, and at the lateral. So basically you have to target this V point. And the lateral view, your angle should be between the angle of the disc and the angle of the facet joints, and midway is your angle. So you make an incision, place the dilator. This is a single dilator system. So dilator followed by a sheath, and then through this sheath you would operate. So dilator over which the sheath is placed, the dilator is removed, and then you put a scope in. And this is the image you would see. This is medial, lateral, rostral, and caudal. So you do use RF or plasma, coagulate, and take out some muscles with disc forceps. And then basically you identify the junction where the rostral and caudal lamina would meet. So coagulate. This is a very important step to identify proper anatomy. So it takes some time to proper identification of anatomy and hemostasis. The more time you spend here, better it is. So then you identify this rostral lamina, this is caudal lamina, this is ligamentum flavum, and this is lateral mass. So medial aspect of the facet joint you have to identify. And then with dissector you separate the underneath ligament and soft tissue from the bone, and then you use drill. So I'm using here hooded burr, which is with a protection sheath, and taking out medial aspect of the rostral lamina, lower 3 to 4mm. So basically it's a keyhole laminoforaminotomy. You take out the lateral part of the superior and inferior lamina as well as medial aspect of the lateral masses, facet joint basically. So drilling of superior lamina, lower part and lateral part. And then now we come to drilling of inferior lamina. So upper 3 to 4mm is sufficient. One can use diamond burr as well here. Once the drilling is done, you will get punches. 1 or 2 millimeter punch can be used. Again, dissecting and making sure that you don't bite the root with the punch, and then you use punch now. So maximum 1 or 2 millimeter punch you can use, and then that gets you into the foramen, and then you can see the glimpse of the root. The inferior lamina is taken out more as compared to the superior lamina. You try to see the junction of root and the cord. You can see that's the root. This medial third or medial half can be safely taken out. And that is the end of the laminotomy. That's a big fragment. In this case, you have to take out the scope again and reinsert. Otherwise, it may damage your light source. And then you can see this is rostral and caudal root. And basically, you have to go here beneath the root. So after doing this adequate laminoforaminotomy, you dissect beneath the root and fish out the disc. Whenever there is a hard disc, you may just do a laminoforaminotomy, and that is sufficient, posterior laminoforaminotomy. If it is a soft disc, you dissect it out and fish it out with a blunt hook probe. Here it is important that you can retract the root superiorly, but avoid retracting the cord medially. That increases the safety of surgery. You can see there is a big fragment coming out. And now you can use disc forceps and take the fragment out. The best part in endoscopic foraminotomy is blood loss is very minimal as compared to open or MIS. Otherwise, always you will have fear that there will be bleeding during the surgery. Don't be happy with just one fragment. There may be few more fragments. So try to dissect and make sure that you achieve a good decompression. So there are some more fragments coming out. And then again, you can use disc forceps to take this out. And you can see very well the compressed root here. There is some more fragment coming out. And then you can see finally well decompressed root. This is inferior part, this is superior part. And then you confirm again with a blunt probe, make sure that the root is well decompressed and mobile. And that's how we close. The patient had post-operative complete relief of pain and triceps weakness recovered over the next 6 weeks. This is post-operative MRI. This is the beauty of the surgery. Complete well decompressed root, and there is hardly any footprint left behind. And this is a CT showing very small window through which we operated. The postoperative protocol is ambulatory on the same day, discharged next day, and there is no collar is used. There are complications are post-op paresthesia, CSF leak, post-operative instability. The best advantage is minimization of intraoperative blood loss, smaller incision, minimal soft tissue damage, shorter hospital stay, less pain, faster return to activity, and basically it's a motion preserving surgery. Again, identification of V point decompression of root, disc removal, and these are steps. The points to remember, there is a learning curve. So begin after getting sufficient experience of full endoscopic lumbar cases. Case selection has to be proper. Sheath position should be as close to lamina as possible. And don't start fenestration till you identify proper anatomy. And don't get panic with epidural blood, and avoid cord retraction at all cost. This is for youngsters. We have a fellowship opportunity, long-term fellowship of 2 years at our hospital beginning 1st Jan. And we have short fellowships from NSSA approved just yesterday. So that is for 1 month to 6 months. Thank you. Endoscopy is angulated. It is 25-degree angulation. So you can see much better without retraction, sir.
Yeah, so that why didn't you start using that also in this discectomy?
Sir, anterior discectomy, you mean anterior discectomy, sir?
Yeah. No, now you have done this surgery.
Yeah.
If you put a fiber optic or this thing, you can see much better, no?
Okay, flexible you mean?
Flexible.
Oh, flexible spine endoscope still not in the market.
No, visualize, is there any residual disc?
Okay, yeah.
Instead of even detecting that
Okay.
amount of cord in the cervical region,
Right.
you put a endoscope, a fiber optic, and then see how it works.
Yeah, that's a good idea, sir. Never thought about it.
Thank you.
Thank you, sir.
Thank you so much, Dr. Rakesh. Can we have Dr. Sai Kalyan up next to speak about tubular microdiscectomy?
Good afternoon, everyone. First of all, I would like to thank Dr. Manas sir and Dr. Savitri Shastri for giving this opportunity. This is our team, and I am indebted to my team for their constant support. Of late, we have been seeing the importance of these paraspinal muscles, that is the multifidus longissimus muscle and iliocostalis muscle. And the concept is the less damage to the multifidus muscle enhances the early recovery. And that's the reason why all these wet endoscope systems, dry endoscope systems, tubular systems have become so popular. So this is how we dog the tube. According to AO spine recommendations, this is the position of the surgeon, assistant, C-arm. Of course, it again depends upon the comfort of the surgeon. So I prefer, the position is in prone, and I place the patient on the bolsters, and I ask the OT assistant to break the table so that the interlaminar space opens up. So these are the different serial dilators, and we all need to be well acquainted with the diameters and the lengths of these instruments. So this is a 31-year-old guy who had complained of low back pain initially to start with, and later it started radiating to left leg, and we tried to manage him conservatively, but the left leg pain worsened, and there was an L5-S1 extruded disc here. L4-5 was also there, but it was not symptomatic. So after initial marking of the L5-S1 space under fluoroscopy, after painting and draping, I marked the level there, and I usually mark the midline of the spinous process, and from there, you can see here, I'm trying to go laterally and dip it where the spinous process dips. And from midline of the spinous process, I take 2 centimeters, and in between the dip and this 2 centimeters mark, I'm going to take the incision. There are no hard and fast rules for this. The idea is when you're addressing a disc, it has to be more medial, and when you're addressing the over-the-top laminectomy, it has to be more oblique and lateral. So after infiltration of lignocaine with adrenaline, based upon the tube which you are going to dock, around 1 to 1.5 centimeters of incision is taken. Skin subcutaneous tissue is incised. The catch here is the fascia has to be incised generously so that we don't have any obstacles further so in waggling the serial dilators. So you can see here the serial dilators are slowly placed in between the interlaminar space and waggle it craniocaudally, mediolaterally, and you need to use both your hands to get the tactile feedback. And if you can see here, if you place gentle pressure on the thumb and you can scroll over the lamina, the interlaminar space, and some surgeons prefer using a guide wire, but I don't use it because there are chances of perforation into the thecal sac. So we need to spend adequate time here, ample time here, so that the next steps of the surgery would be easy. So we get a good tactile feedback here. We can feel the lamina, the interspinous, the spinolaminar line, and the facets. So after placing these serial dilators, here we can see what is the length and what length tube we are supposed to use. So finally, it has to be docked in such a way where our area of interest is. If it is foraminal disc, we need to be slightly higher up. And if it is inferior migrated disc, it has to be slightly lower. If you can see here, after the docking of the tube, we try to, here we can see the lamina, the spinolaminar line, and the muzzle over the interspinous, the muzzle over the interlaminar space is removed. I usually tend to preserve the muzzle over the facet because they say that it's better to even preserve the facet joint and even not run your bovie over it. So these are the landmarks: the spinous process, spinolaminar line, and lamina. So I use generally a diamond drill, and 3 to 5 mm of lamina is drilled so that we reach the insertion of the ligamentum flavum. After this, with the help of the Kerrison punches, ideally number 2 Kerrison punch, I'm going to remove the bone chips underneath the lamina. So if the interlaminar space is adequate, there is no need to remove the bone as well. But for beginners, it's better to drill and find the attachment of the ligamentum flavum. So with the help of Kerrison's ronger, we are going to remove the bone, and we can see the outer layer of ligamentum flavum. I usually take a sharp dissection over the ligamentum flavum with 15 number blade, 15 number knife, and after opening this, I again take this. I take this ball hook and try to dissect all around, and with the help of 2 number Kerrison ronger, we open the outer layer of the ligament, and you have to be ambidextrous when you are using these upcutters. So medially, laterally, cranially, and caudally, the outer layer of ligamentum flavum is removed now. Now here we can see, we try to detach the ligamentum flavum from its insertion, and again remove it cranially, caudally, medially, and laterally. So while doing it laterally, the catch is you need to dissect it, lift it, and then cut it, so that most of the time laterally we find the traversing root there. So it's better to dissect like this, lift it, and then cut it. So we can see the epidural fat here. And other thing is the microscope has to be maneuvered properly to the area of interest. And underneath this ligamentum flavum, we can see the root, and I'm trying to retract the traversing root, and there we can see the fragment. And here, this is another step where we are supposed to spend ample time to dissect the disc fragment from the traversing root and the thecal sac. So you need to spend some time here, and if possible, try to do a dynamic retraction of the traversing root and thecal sac rather than the static root retractor. So I'm trying to separate the extruded disc fragment from the traversing root and trying to deliver the disc fragment. So there is some attachment, so I'm trying to separate it from the traversing root here. And once you feel that it is completely separated, then try to remove it completely. Just one more minute. So this fragment is, the extruded fragment is, which was adherent to the traversing root underneath, has been separated, and now I'm trying to, yes, the whole disc fragment is delivered. Later, for the loose fragments, discectomy is done, and the other thing is we place a suction cannula and give a proper gush of saline and saline wash, so that the disc fragments, the loose disc fragments which are there inside, are delivered out. After this, we see some of the loose fragments here, and of late we started using the laser to coagulate this loose fragments. And while using the laser, one needs to be careful that you're not going to go anteriorly or go and burn the end plates. So that is the important thing. And for this epidural hemostasis, we ideally place a gel foam with Surgicel, pack it, and then after saline wash, remove it. So this is the final thing. The thecal sac and traversing root are free from compression. Give a proper saline wash. Place a gel foam Surgicel. Try to remove it after some time. I would like to thank Professor Zelili, from whom I have learned this technique. Thank you.
We have Dr. Tirmal speaking on minimally invasive TLIF. We will break for lunch after this. I would request everybody who's in the afternoon batch for the hands-on to make sure that they eat their lunch. And once the current batch is done, we will shift you guys to the OT.
Good morning, everyone. Thank you, Manas sir and Savit, for having me here. And congratulations for the successful 4-day show. It's really a great learning experience. Today I'm going to talk about MI TLIF, and as we are all aware that the lumbar interbody fusion has many ways to go ahead, and TLIF is one of the easiest and simple to learn, and with not a much steep learning curve like endolif or olif. So I'm going to give my short video on TLIF. This before that, I'll try to give a small introduction of the anatomical approach. This is where this is the foramen in the disc space, and this is 4 and 5. Sorry, this is the cranial. Video is gone. So this is a cranial end, and this is a caudal side, and interlaminar space, and the spinous process. This is where the facet which we are supposed to remove, and the tubular retractile docks at this place, and the IAP has to be cut at this L-shaped junction, where this is where our cuts will be. This is a laminofacial junction, and at the pars to remove the IAP, and another cut will be at the SAP, where we have to cut at the upper 1/3 of the SAP. This is the upper 1/3 of the SAP, which we are supposed to cut, and making sure that we are not going into the pedicle. So this is what we are supposed to decompress. The exiting route will be here. This is the disc space which we are supposed to open up and fill with the cage and the graft, and the SAP which we have to cut, and this is the laminofacial junction of the IAP and the pars which you are supposed to cut to open up the entire joint space to do the lumbar interbody fusion. This is about a 75-year-old male who presented with severe claudication symptoms, and he had rest pain also, where we plan to do the bilateral fasciectomy and fixation with the percutaneous screws. So the patient is position prone, and after the placing of the guide wires on both sides, I place the percutaneous screws, percutaneous guide wires, and this is where we dock the guide wires, and this is after placement of the rod and for the distraction on the opposite side, we are planning to do the fasciectomy on this side, and placing the rod and screws on this side, and we gave a gentle distraction to jack up the disc space. And the tubular dilator system will land into the ipsilateral fasciectomy site, where we are planning to do the discectomy and the fasciectomy. We are making sure that the system is exactly onto the disc space which we are trying to do the open up the facet. This is a system which we are using. And after the stabilization of the disc space with the rod, then we start opening the exposing the facet. This is the joint space which we are supposed to identify, and this is the medial, lateral, cranial, and caudal surface, and this is the interlaminar space. And our facet cut will be from the medial. This is not working. So our facet cut will be from the laminofacial junction of the IAP and the pars. This is where we are opening up the IAP, and next will be the superior auricular facet, which we are seeing laterally. This is the superior auricular facet, and this is the joint space which are. This is the joint space, and the cut will be from the laminofacial junction here and the IAP, the pars here, which will open. Sometimes, if the pars is already fractured, in some cases, the pars cut might not be required. This is the cut at the laminofacial junction, and this is the cut at the pars. And if you are able to remove in a single piece, you can remove, as otherwise you can make it into multiple pieces and remove in piecemeal. Next, we'll direct the tubular retract slightly laterally and remove the muzzle over the SAP upper 1/3. This is the ligament, and this is the medial side. This is where we are going to give the cut to. And if you're having any doubt, you can check with the dissector that you're not landing on the pedicle of the inferior vertebra. And using the chisel, we'll give one more cut onto the SAP. And we can remove in a single piece or in multiple pieces. Next comes the removal of the hypertrophied ligamentum flavum to expose the disc space. The white shiny thing which you'll see underneath is the disc space, And the things which might can get damaged are the cecal sac medially, are the exiting root here underneath the upper pedicle, which we need to be a little careful. After the annulotomy, then we'll introduce the shavers. We'll introduce these shavers and gently tapping it with the shaver and making sure that the shaver is lying exactly in the disc space, not going anteriorly into the retroperitoneal space, breaching the ALL, or it is in the canal. Making sure that it is exactly lying in the disc space, and introducing serial shavers, we can roughly identify the disc size which we are about to place. And we can prepare the end plate by using the chisel, the disc fragment which we are removing. And while removing the disc also, we should make sure that the punch is exactly lying in the disc space only, not pulling the sac from up or going ALL beyond the ALL. Next, we use the funnel to fill the bone graft into the anterior disc space, followed by introduction of the cage. Either if the disc space is very much collapsed, we might as well use the expandable cages. Once the cage is at this place, turn the XC arm into AP and make sure that this is the spinous process. Make sure that it is lying exactly in the mid place as it is supposed to be. Now I'm tilting the table tubular retractor slightly medially, and I'm trying to open up this space where I'm trying to do the over-the-top decompression to go to the opposite side of the disc space to open up the thecal sac and decompress the thecal sac completely. Now this is the ligament of flavum. I'm going above the ligament of flavum. I'm below the level of the bone and undercutting the spinous process here. This is a hypertrophic flavum which I'm removing. And this is a thecal sac which is removed from one end to another end. And in this case, after removal of the opposite lamina, I've gone to the opposite side and placed the tubular retractor on the opposite side and cut the opposite face also, so that I could open up the opposite foramen also. This is the opposite side of the root. Now I introduce the tubular retractor on the opposite side and cut the facets on both sides. This is the post-op incision. This is both the facets lamina have been cut. The post-op construct with the cage, you can see. The post-op CTs, which we mandatorily get done for all the patients. Thank you.
We can break for lunch now. Lunch is served outside.
బ్రాండింగ్ మా బ్రాండింగ్ ఇక్కడ NSSA బ్రాండింగ్ ఏం జరుగుతుందో చెప్పాలి ఏ డాక్టర్ వాళ్ళ డాక్టర్ అసలు ఏమో పెట్టుకుంటున్నారు ల్యాప్టాప్లో NSSA రూమ్స్ అనిపిస్తుంది నేను ఈ బ్రాండింగ్ నాకు లాభం నేను ఇలా
Talk from Dr. Arun Gowda, who is going to speak on how he manages a vertebral artery that comes in the way of his C1, C2 fusion.
Yeah. Yeah, you can just call him. Yeah. Yeah. Good afternoon, everyone. Thank you. At the outset, I would like to thank Dr. Savitri Sastry sir and whole organizing team for the opportunity. So I'll be talking I'll be presenting my work on how I mobilize vertebral artery in C1 C2 reduction fixation in a post-traumatic AAD case with anomalous vertebral artery. So here is a patient. So basically, Atlanto-occipital dislocation refers to the motion between It's not the one. Sorry for technical glitches. So basically, I'll be talking about work on how I mobilize vertebral artery. For this is basic. I can skip this slide. Coming to the history, we had a 63-year-old male patient who presented the complaints of left side weakness following slip and fall, with history of LOC for 10 minutes following fall. And on examination, there was left side significant weakness, approximately 3/5 in all 4 limbs, with significant weakness in the hip of 0/5, with exaggerated deep plantar reflexes, such as human paralysis. So with this background, we evaluated the patient with routine basic X-ray was done with history of significant Atlanto-occipital dislocation. So we're not sure whether pre-existing AAD or this post-traumatic. But while after getting a CT, it obvious there was assimilated C1R with history of possibly pre-existing AAD, which was aggravated by post-trauma. So patient was further evaluated with CT scan and CT vertebral angio. CT vertebral angio is the one very important investigation which it will help us in exactly analyzing the 3D reconstruction and also analyzing the vertebral anatomy so that we can plan accordingly. We are also sure of what exactly we need to do preoperatively. So this is suggestive of like left side there vertebral anomalous vertebral artery. Right side was almost normal, but left side there was vertebral artery which was going between C1 C2 facet joint, and also there was significant spondylolisthesis between C1 C2, which can be possibly because following which may be pre-existing or which can be aggravated by post-trauma. So with this background, patient also underwent MRI with issue of significant cord contusion at the level of foramen magnum, which is possibly caused for post-traumatic significant weakness on the left side. So patient was, with this background, patient will plan for surgery and taken up and planned for C1 C2 fixation and partial foramen magnum decompression. So patient was positioned for standard prone position with concord position with patient and traction. Approximately used 4 to 5 kg traction and similar exposure of occipit to C2 with keeping plan of standby OC2 fixation in case C1 C2 fails. So since there was significant spondylolisthesis, I planned for using of reduction screws. So that without reduction screw, I think it will be very difficult to mobilize C1 over the C2. So since there was anomalous vertebral artery on the left side, I prefer to do it on the right side so that if once I'm doing the right side, so I'll be in the, even if something unusual happens on the left side, have some time to, I won't have time to fix this right side. So what I realize is any successful C1, C2 fixation depends on proper delineation of the anatomy and good dissection. So good, like periosteal dissection gives a delineation of anatomical location so that it will be easy for fixation of screws. So this, I prefer to do it in the right side. So most of the time I prefer to take out the C2 ganglion and opening of the joints well. And so once I'm done with the right side, I came to left side so that alternatively I can do left side, right side. So I'll get some time. If there is some bleeding on the one side, I can pack it for some time and they go to opposite side. So that we can control bleeding. So left side, since the vertebral artery anomalous and exactly it was lying on just below the C1 joint, so I nibbled out bone piece by piece so that exposing the left side vertebral artery so that I can nicely mobilize it and create some space to put C1 lateral mass screw. So this is I'm dissecting on the left side, nibbling out the left side C1 posterior arch, which was hospitalized to the hospitalized. So I prefer to use a diamond drill at this stage because the drilling bit can cause injury to the vertebral artery. So this is the left side, you can see the vertebral artery below this bone. So once this amount of dissected was done, there was some amount of ooze. I packed it so that at this stage flow seal will help you to control bleeding. So we can give some time and go to the opposite side. So at this stage I moved to the right side so that after that I opened up the joint. I tried putting the good chunk of bone piece, but it was very difficult. So I made different pieces, multiple pieces, and I put in the joint space. So once bone was packed, we can go with putting the screws. So so nice exposure of C1 joint complete lateral mass will help us in identifying the anatomy and putting the screws. So lateral mass I prefer to do delineate the complete lateral mass, and I prefer to take 5 to 10 degree superior angulation and 5 to 10 degree medial angulation. C2 I prefer to do the pedicle screw fixation. So ideally, after delineating the complete pedicle, I prefer to put the screw in the superior and medial most segment of this. Easy to it will be very helpful for the direction of the joint. So I am finishing the work at the right side, which is normal side. So once done on the right side, I come to the left side, so that even if some vertebral artery injury, so we have some time to fix it on the left side. So once I'm done with the right side, I came to the anomalous side. This is the anomalous left side, because we can make out the vertebral artery was anomalous on the left side, and also it was running between C1 C2 joint. I carefully dissected and mobilized the C1 vertebral artery inferiorly. Then later I nicely identified lateral mass, and then made a burrow and could put the C1 lateral mass screw safely. Again, reduction screw on the left side. So sometimes I prefer since this vertebral artery handling was there, I used some gel foam and also Teflon pads just to prevent vertebral artery injury. Then standard pedicle screw on the left side as well. So once it's done, I made some space in the C2 bone to make the rod to fix. Then again putting the rod carefully, then again using torqued deinsulator to prevent inadvertent pull out of the screw. So once it's done, so that erection screws, extra bits has to be taken out. And since there was handling of vertebral artery, I prefer to use sprinkling out a bit of papaverines to prevent vasospasm. So since there was hospitalized C1 posterior arch of the C1 to the occipits, I took out that minimal decompression of at the level of foramen magnum, since there was significant compression over the foramen magnum. So sprinkling out a bit of papaverine to prevent vasospasm, and nicely packed bone chunks at the joint. Then this is the post-op X-ray showing good reduction of C1, C2, and again AP view. This is showing significant reduction in the Atlantic dislocation, and also post-op wound looks good, and patient showed significant improvement after surgery. He came with significant weakness of the left side. He couldn't even walk without stand without support. This post-surgery, after 6 days after surgery, could walk well. This is again a case 2 This is the patient with, again, the 20-year-old male patient presented with weakness of all 4 limbs since 8 years, which is aggravated since 1 month, and showing mild weakness on the both sides, but mainly on the right side. So this, just to make it a point that even though the patient had significant, here patient evaluated with subsequently, we showed significant, make out significant Atlanto-occipital dislocation with very, you can make out almost approximately, the Atlanto interval are approximately close to 1.5 centimeter. So this is, with even with such a bad AAD, we could get away with, even this patient had anomalous vertebral artery, we could mobilize safely and fix it, and patient achieved good reduction. This is the post-op CT showing good reduction. This is the post-op CT image showing significant, nice placement and good reduction in C1, C2. This is the post-op patient improved well. Thank you.
Thank you, Dr. Arun. Can we have Dr. Kalyan up next, who will show us his way of doing a transforaminal endoscopic discectomy? Another couple of announcements. Buses will leave from the hospital to the airport at 2:30 and 3:30. So if anybody needs them, please let us know.
Good afternoon, everyone. I'll be describing the transforaminal endoscopic discectomy, the inside-out technique. I'll be describing the standard operative technique. First, before I describe the technique, I want to answer this question: is endoscopic discectomy a difficult procedure? Many people perceive it to be more difficult than the open procedure because of few reasons. One is the scope which you are using is an angulated scope. So throughout our residency, we are not used to visualizing a tissue at an angle. So for a beginner, looking at an angle becomes difficult. And when you are not able to identify the anatomy, the procedure appears difficult. Second one is the restricted movements of the scope. As shown in this picture, I can move the scope in and out. I can rotate the scope. But movement of scope in this direction is fairly restricted. So you need to get used to working with restricted movements of the scope. So before I go into the exact procedure, we need to know the anatomy of the disc, how it appears through the endoscope. So see this animation. So as you withdraw the scope, progressively your field of view changes. So how does it change? So as I'm slowly withdrawing, initially I was seeing the disc, try to correlate both the pictures simultaneously. As I'm going out, the disc goes, the annulus comes in picture, then the epidural space, and then the facet joint. So this is the picture which you'll be seeing through the endoscope. So as you keep going in and going out, you should be able to appreciate that you are seeing the blue color disc, which is stained with methylene blue, the white color annulus, then the yellow color epidural space. So this is in the live one. So try to understand how the anatomy changes. I keep withdrawing my scope. This is a discal material. As I keep withdrawing the scope, more and more annulus comes in picture, the white colored annulus, and then we have the epidural space. This is the epidural space. So this is the picture which you should be able to identify. The inferior part of the picture was showing the disc which are partially removed. The middle horizontal fragments are the annulus, and this portion is the epidural space. So also try to visualize how the picture changes when I move the scope. On one side, I'm seeing one end plate. When I'm moving my scope, on the opposite side, this is the other end plate. And in between, you have the annulus in the upper part of the field and disc in the lower part of the field. So as I keep removing, in between the disc, you will see a black opening, which is the annular fissure. So let's come to the procedure proper. Marking of the lines, the midline view, which is marked in the AP view, the discal line in the AP view, the disc inclination line, which is marked in the lateral view. Then we measure the height of the disc inclination line. That gives a distance from the midline for the entry point. Once I enter, I place a guide wire. Over the guide wire, a dilator goes in. Over the dilator, a cannula goes in. This is the final position where my cannula is in the posterior 1/3 of the disc. So coming to the discectomy proper. So it's in few steps. So initially, we remove the disc which is stained with methylene blue. Then once you remove the disc, once you start chasing the degenerated disc, you will be seeing the hole in the annulus. Then you withdraw the scope, then you go into the epidural space. Yeah, coming to the live one. So first one, I'm entering into the center of the disc. So this is stained with methylene blue. So all the blue portion is the degenerated disc. I keep chasing the degenerated portion. As I keep chasing it, automatically I will be reaching the annular fissure. I'm removing the degenerated disc, which is being helped by methylene blue. So as I keep chasing it, you can correlate with this diagram. The blue color is a degenerated disc, which I'm chasing it, trying to remove it. Slowly you will be able to identify the hole in the annulus, which is entering into the epidural space. You can start appreciating the black colored hole in the annulus. I'm trying to clear that hole, delineate the hole with the help of radio frequency. Once the annular fissure is cleared off, you have used a radio frequency, we withdraw the cannulus, as I have shown in this picture. I'm withdrawing the cannula. As I keep withdrawing, more and more of annulus comes in the picture. The epidural space has come into picture. This is the epidural ooze. Have controlled the bleeding. I'm using the radio frequency probe to make a clear plane in the epidural space. At the same time, I'm delineating the superior and deeper surface of the annulus. Then once I delineate the annulus, this is the annulus, this is the epidural space, I cut this annulus. This is annulotomy for wide exposure of the epidural space. This is the annulotomy. Once I've delineated the superior and inferior surface of the annulus. Once I do this one, you can see the thecal sac pulsating freely. The more and more of thecals are coming in picture. Once this is completed, this is the free thecal sac. I use a hook to make sure that there is nothing in the epidural space. I ensure that no fragments are left there. You can see the fragments. Fragments will be blue stained. This is a final confirmation showing the free pulsations of the epidural thecal sac within the epidural space. I ensure that there are no more free fragments. And then once the hemosis is acquired, I remove my instruments. This completes the procedure. Thank you.
Thank you, Dr. Kalyan. We'll have Dr. Ankit next, who's going to talk about interlaminar endoscopy for a lumbar discectomy.
Good afternoon all. Once again, I would like to thank the organizers for this opportunity to speak in how I do it session. So I'm presenting interlaminar endoscopy. So we know all the surgery, the 70% is planning and 30% is skill. So I give a lot of time to plan my cases for interlaminar or any procedure, particularly when you are doing endoscopic surgery where you need to identify your targets and then hunting those targets. So I will start with this case, a 20-year-old student, first-year student who presented with 1 year back pain, with radicular pain. And he underwent everything, but he had a failed conservative trial. So you can see here he had a L5S1 disc herniation. And if you zoom this, you find there is a apophyseal fracture here along with the black disc, the herniated black part of the disc, and that is the root here. So this would be the target because it is a long-standing disc herniation. So probably this disc would be a hard, maybe calcified, maybe fibrous disc. So that's why reading this MRI is very important. So coming on to the axial cuts, so again zooming in, this is the disc. Again, this is the black part, so probably it's a osteophyte or the hard disc, collagenized disc. Here again, that is the part of the disc. Probably that was the herniated disc, which now it is dehydrated and fibrotic. So this is the root here. And another image, you can see there is a small hump which is lower down at the level of the pedicle, and then that is the root compressed against the facet by the disc herniation. All patients undergoes for dynamic X-ray. There is no instability, and we see the interlaminar window also. So pre-operative preparation, these patients we have the day before surgery, we have a lot of discussion with patient with clinical confirmation on which side the symptoms are more, whether he has symptoms on the opposite side also. Counseling about the surgery and outcome is done. All patients are started pre-operatively 1 day prior on gabapentin and paracetamol 1 gram TDS. Patient is given a morning bath with a scrub, betadine scrub, and he receives a prophylactic antibiotic 30 minutes before the surgery. And all patients, the interlaminar patients, are done in general anesthesia. This is the position. Patient is positioned prone on bolsters with the flex table with reverse Trendelenburg, and so as to open the interlaminar window. This is typical OT arrangement. You see the surgeon, every equipment, larger equipments are on the opposite side of the surgeon, and you have a nurse beside you and the other equipments. So I use this cranial drape for interlaminar surgeries, and I put a rolled sponge below this to make a dam, which shifts the water to the outlet, and the outlet is connected to tube which goes into a tub. So these are the basic instrument. I use 4.2 working channel instrument with 25 degree. Before putting the knife in, we confirm the antibiotic dose, working equipment, side level is confirmed, and again the radiology is checked, and we confirm that the radiology of the same patient. So this is the video. So first, marking is done with in AP view with the C-arm. So landing is basically just lateral to the midline, just inferior, on the inferior, the lamina. In lateral, I put a needle to see the direction, and then incision goes up to the fascia, then the dilator, then over which goes the sheath. And that is the final landing for L5S1 this case, AP and lateral. So this is the video. So first, you see the muscles and some fatty tissue. So after clearing these tissue, I expose the ligamentum flavum. In these patients, L5S1 with such a large window, you don't need any drilling here. So this is the ligamentum flavum, which you have to cut, make a flavotomy. So that's how it is cut. So your annulus cutter should be always in your vision, what you are cutting. So as you can see here, all thing what I'm grabbing, I'm seeing it perfectly. So keep on cutting till you see the change of the color. The yellowish thing, now it's turned graying, slightly grayish. So now I use a dissector to split this rather than cutting it further. So this splits this ligamentum flavum, and then you can make the window wider with the Carrison punches, like this. So once you are sure, once you have opened this flavum, the pressure of this saline pushes your dura ventrally. So now there is less chances of injuring the dura, so that you can use your annulus cutter further to make this step faster. A window of around 8 to 10 mm is created, depending on the size of the herniation and the direction of the herniation you are planning. So this is standard, the procedure for a single level herniation. This much of window is sufficient, and you keep on removing till you reach the lateral border of the root. So now you can see this is the lateral edge of the flavum, which is being removed. Now after removing the fat, you can see the root which is humped, below is the disc. So this is coagulated, the fat is coagulated, and just note down that I'm lifting the fat and then coagulating rather than pushing it and coagulating. So that is the disc. You can see clearly the edge of the root. Now this annulus is cut with the annulus cutter or the annular cutter. So once you cut this, these fragments are visible. So this was a chronic disc, so I didn't find a larger fragment. I removed some few fragments, soft fragments, and then there was a lot of collagenized and fibrotic tissue, which was basically thickened annulus along with disc, which was cut with the. Can I move it a little bit further? Just to orient, this is the cranial side, right side, and that is the left side. That's how we hold the scope. Once you make sufficient space, you can rotate the sheath and then remove the fragment further. fragment or the part of the annulus, hard disc, or even the osteophyte if they are present. After every 10 minutes, the nursing staff keep on telling me that the 10 minutes there, so you just remove your sheath. So I remove my sheath and then again goes back. Coagulate the things, vessels, lot of vessels, inflammatory vessels are there, so coagulate these vessels so as to keep your vision clear. So forward कर सकते हैं क्या? So the disc, that's all. We remove the disc, and the root is completely decompressed. And post-operatively, all patients are kept in recovery room for 30 minutes. They receive antibiotics coverage for 24 hours, analgesics as per the need. And same day, the patient is ambulated with LS belt, and VAS score is noted, and next day discharged. Thank you.
Thank you, Dr. Ankit. Up next, we have Dr. Anil Kumar, who will demonstrate a UBE discectomy.
Good afternoon. At the outset, I'd like to thank Manas sir, Dr. Savitar, and Dr. Kalyan for giving me this opportunity. I'm a middle-aged neurosurgeon who is very comfortable with the microdiscectomy, but the pressure of the endoscopic teams and the patients who ask for small scope or laser things. So I was forced to learn endoscopy. And then when we search, I felt the other procedures were really cumbersome, and I thought this is a very easy one to pick up. So this is my very initial experience. I've done around 10 cases, and so yeah, it's not very sophisticated. So this is a patient who had a right side radicular pain, and we can see there's an extruded L4-5 disc. So like in any other things, we mark the midline and then the medial pedicular line and then the discal line. And then these are the markings on the patient. Then what we do is we try to triangulate using 18 gauge needles so that we'll have a rough idea of how to, where to place the ports and the direction of the port. This is how we can place it. Usually what we do is we take the pedicle and just beneath the pedicle we mark the entry points. So the superior and the inferior ones, and we triangulate towards the spinolaminar junction. So we pass serial dilators, and when we pass the serial dilators, what we try to do is we try to hit the bone, and from then we try to elevate the muscle from the periosteum. We use medial to lateral rocking movements and from cranial to caudal rocking movements. And as we do it, we, with our tactile sensation, we can feel the spinous process, the lamina of the upper and the lower levels. So before we go in, we usually have everything with our hand. We can feel everything. So once this is done, we pass the endoscope and the RF electrode. So this initial probably 5 minutes will be like very confusing because the scope is there, you see all the tissue, some bloody fields, and you pass your RF, and that hits the bone. It appears like you are near, but you cannot see the electrode. But gradually, as you rotate and see, once you get the hold of the probe, it's better you never leave the site of it, and you just try to coagulate the whole of the muscle, and then try to see the bone. Once we see the bone, then things appear a little more comfortable, and we try to scrape away the tissue from the bone. So once we are there, we just initially confirm with the CM to the level, and to see whether we are medial or lateral, or at what point we are there. So now we can see we are right at the spinal laminar junction. My RF probe is at the right. So from here, it's like our regular microscopic surgery, only is that you have only one hand to operate. We gradually, what we do is we try to remove the tissue from the medial to the lateral. We can see that from the spinous process, we have removed the tissue along the laminar edge. And then we also try to coagulate the tissue medial to lateral. As we come lateral, we sweep away the tissue from the lamina towards the inferior articular process. There we can see the inferior articular process. That is the inferior articular process. After some time of dissection, what we will do is we can see that is a L5 upper part. That is interlaminar space. There is the spinolaminar junction. And as we go laterally, we see the inferior articular process and the lower border of the lamina. So once that is done, we start with the drilling. The initial drill is placed at the spinal laminar junction, and we try to slowly come from the medial towards the lateral. And as we drill, there is a lot of dust which is generated. We'll keep drilling intermittently. And as it clears, again we start to drill it. So after some amount of drilling, what we try to see again what is happening with the in IAP. So that is the IAP which is still preserved. So we are not. It appears like we have done a lot of drilling, but it's not that much. So we are rechecking it. Some part of the bone can be removed with our regular kerisons. This is the drilling. So what we do is we drill till the middle border of the IAP, or a little into the IAP. So after that, as we drill cranially, we can see the small opening where the flavum ends, and we can drill a little more, and once that flavum edge is seen, we can start to dissect the flavum from the lamina. And then we can remove the flavum as per the regular what we do. We just confirm our level. These X-rays are not necessary, but it's always better to confirm. The lateral border of the root is seen, and then we retract it. We can see the disc coming out there. And this is our regular discectomy. There is some more part. We probe again. That is how it is coming. Thank you.
I think we have to wait for Dr. Sukumar Sura and Dr. Chok to come over from the theatre to present. They're coming, 5 minutes.
Wait for a couple of minutes for Dr. Sukumar and Dr. Chuk to come back up from the OT. Any questions for anybody else? Pent up questions from this morning.
We have some time. We need feedback from you people that how conference can be better next time. Dr. Rajkumar, Dr. Venkatesh, before going, just give feedback.
Oh, so you are the better person to. Manas sir is very senior and he is very experienced in organizing this. So no way we can do better than this. So that is my opinion. Thank you for the opportunity, sir. Thank you.
hands-on and how I do it, both are very good. And how I do it, I have one small suggestion that, so even though everything is shown, but some procedures has to be shown from longer time, so that the juniors can learn the things. Endoscopic foraminotomy, how to put the incision, marking, everything. It is there, but some more elaboration, that's all.
I think we will request the speakers, means next time probably we'll tell one person to present just on positioning and marking, next one other procedure and all those. When you tell to make a half an hour, many of them land up with coming with a 10 minutes video.
Okay. Good afternoon. And my topic is how I do it, UV fusion. So this video is actually made for the resident of Korea. So it's kind of the instruction video. For this patient is L3 for right side approach for the degenerative spondylolisthesis with degenerative scoliosis and foraminal stenosis with for right side. He actually underwent unsuccessful laminectomy a few years ago. So this is initial part. This is right side, and I'm doing the soft tissue dissection. This is the medial board of the upper lamina. I mean L3 lamina, and then this is facet joint. And for fusion, you need extensive soft tissue dissection compared with the laminectomy or discectomy, and you need rapid and effective bone removal. So I always use osteotome for retrieve bone chips for later use as a bone graft. And when you use osteotome in UV surgery, do not try to make a big bone cut. So big bone cut cannot retrieve through the small hole and usually cause bone bleeding. So I usually make it a small piece and remove it with specialized sharp bone ronjo and try to gather every bone particle as a bone graft after later use. So, and then I usually cut the bone from lamina to the isthmus. Same with the open T-lip. And usually I use osteotome to remove remaining part of the inferior facet joint. So I mean inferior articular process. And then I try to find where is the pedicle. The pedicle is the single most important landmark for disc space and for T-lip. So I try to find where is the pedicle, inferior pedicle. And when I find it, I usually cut it with the osteotome, tip of the superior articular process. And then this patient, the disc space was so narrow, I use a disc shaver. Usually I don't use disc shaver. And then check the position of the disc shaver. And usually I do not check C-arm during fusion nowadays, but in this video, I check several times for the instruction. So you can see the position of the trial over the across the midline. I will use 2 cage technique in this patient, and then pack the disc space with the bone chip, and then insert a longer cage cross the midline, same with the T-lip, 1 kg, and check the position. And one more, and check the position. And you can see the positioning of the kg. And lastly, I check the lateral C-arm, where are the cages are. This is end of the T-lip, and then we should do percutaneous screwing for the, where is the, okay. And second case, I still prefer Oblique over endofusion, but in fusion extension, I prefer UV fusion than Oblique because we can avoid big incision and scar tissue dissection when we are doing open surgery. When we use UV fusion, you can remove screw very easily on the endoscopic view. This is how we can remove old system on the endoscopic view, dissect soft tissue from the instrument, and then remove nut screw. But please keep the nut at the endoscopic view field. If you try to remove it with the nut screwdriver, you will miss it in between muscle. It's very difficult to find when you miss it in the soft tissue. So keep it in the endoscopic view field and then grab it firmly with a forceps or some kind of other means of forceps, and then remove remaining rod and screw under the view of endoscope. You can do it very easily. And I usually go, this patient, I approached left side, not right side. So this is the L5 pedicle screw remover. And then I dissect the facet joint and isthmus. This is facet joint, lateral facet joint, and this is isthmus. And you can see accessory spinous process under the scope retractor. And then I dissect accessory spinous process and try to find L4 transverse process. And here is the tip of SAP. And this is the end of, and then so the same with the virgin surgery. Try to remove bone with osteotome. Usually osteotome is very effective in terms of rapid bone removal and achieving bone pore rate use as a bone graft. And try to retrieve every bone piece. Can I have a kind of, okay. And then I identify pedicle with drill, the L4 drill, L4 pedicle, and ligamentum flavum. And then check where is the inferior pedicle is, and check disc space. And then cut the tip of the SAP with osteotome. Same with the right side. Same with the open microscope, open minimally invasive TLE, and then same procedure with previous surgery, the disc space preparation and curettage and end plate preparation and cage insertion. So this is the final product of this surgery. So UV fusion has a bright future, but still there are something to be solved. The technically very demanding, and sometimes it takes too much time. But I think it will be a part of the mainstream of future lumbar fusion surgery. Thank you. And actually, there will be a World Minimally Invasive Spine Surgery meeting will be held in Daejeon City, December in Korea. So please come and enjoy the wonderful world of endoscopic spine surgery in Korea.
So thank you, Dr. Chuk. There are no other questions. I'll request Dr. Sukumar to present. Please sit down.
Good afternoon, everyone. So, after wonderful talk by Dr. Chuk, so you do uniportal or biportal, the concept is same. Yes. Yeah.
Dr. Chuk, can we please have you up on stage? Dr. Chuk is the current president of the Korean Spinal Neurosurgery Society. He couldn't be there on 19th when we felicitated the other international faculty, and Dr. Chuk has been hugely active in the endoscopy UB workshop today. I'd like to invite on stage Dr. K.V.R. Shastri, president of the Brain and Spine Society, and Dr. Selvan, president-elect of the NSSA, to felicitate Dr. Chuk.
So the idea of fusion is the interbody work need to be done properly. You do whichever way you do MIS techniques, you do monoportal, biportal. So the idea is to have a good interbody fusion. That's what the end point we want, a decompression of the neural structure and the interbody fusion. That's what whenever we want to do a fusion, we intended to do this. But there are various techniques we've been practicing, from open technique to minimal invasive technique to endoscopic assisted technique to endoscopic techniques. But as you know, the minimalism came to prevent, to avoid the collateral damage, especially the muscle tissue. So there are a lot of techniques been there past 20 years. So it's my own evolution. We started open MIS. Now I do most of the time endoscopic techniques. So definitely there is an advantage. So this we need to understand when we are using tube or endoscope. So what does it give us? The extra vision it gives us when we are using an endoscope. So definitely with the angles what we use today, either a 12 degree, which commonly been practiced now, 12 to 15 degree, and the 20 degree which I use. There definitely advantage of endoscope over a microscope or open method. So best advantage is the reach. So this you cannot beat in any other techniques where you can reach the upper, lower crevice of both ipsilateral and contralaterally. And next is the mobility. You can see the mobility there. Medial, lateral, caudal, cranial mobility can be reached with uniportal. So biportal or uniportal, the debate is separate, but when it comes to monoportal, definitely we can reach whatever extra we want to reach. And second thing is the clarity. So you get the best ultra clear vision because of the clear saline which is always irrigating, and the cavity you have created is small. So that's why you have a crystal clear field. And the approaches, again, there have been various approaches, the transcambian to start with. So most of the endoscopic or endoscopic assisted fusion started with transcambian route, where Professor Saeed Usman did his cadaveric feasibility study. Since then, transcambian is become very popular. Posterior approach, as we all surgeons, open surgeons or microscopic or MIS surgeons, we are used to this technique. So we have modified our own technique called ASERF technique, which I will describe. So most of the techniques which we are there today, all the MIS techniques or endoscopic techniques, you just enumerated in this paper. So most of the benefits are with monoportal or biportal techniques. So again, when you see the outcomes, definitely it scores. The endoscopic techniques are far better than the open or conventional techniques. So what did we do is we added extra dimension to the monoportal technique. And as Professor Chug was telling, removing piecemeal is good, easy, but there is a lot of bone bleeding when you are removing a piecemeal. So whenever we are operating on elderly patients, the bone bleeding is too much. So MIS, Dr. Rakesh is here who does the regular MIS T-lips. Agree with me that removing a bigger chunk of bone gets us a bigger graft and less bleeding. So what we started doing is the same amount of bone removed in MIS technique. We try to remove the entire bone. You can see here the entire bone, that is the entire descending facet, a part of lamina, flush to the pars. So we remove a part of pars here, the entire descending facet and the part of lamina as one piece. So how does it help? It helps us getting a good graft, very good graft, which we do as good as an open surgery or more than what we do in open surgery. The next part is once we remove this, again, the end plate preparation. So you get the best of the best end plate preparation with this technique because we are posterior, and you can see the anterior annular fibers. So we can go as anterior as possible so that we can pack a graft better. So we can pack the graft as much as possible. We usually pack somewhere between 6 to 8 cc depending upon the size of the space. And you can see again always there is a debate. If we use a wet endoscopy or irrigation, can fusion be same as dry endoscopy or open or microscopic surgery? End of this, you see a very good clot when after placing the graft. So it clots immediately, and you have a very good sealant there. So there is no worry about the fusion. And Once this monoportal work is done, what we do is we use a screw port where we intend to put a screw. The same port is used to put the cage. So how does this help is the trajectory. When you put a cage through the same hole or same endoscopic route, it becomes like a pliff. The angle is not enough, so we come laterally. So this gives us good trajectory, and this scope is retracting the root. So through the scope, you pass a dissector and retract the root. So it's a visualized cage insertion. Still, you are not damaging any structure. You are dead sure of your cage insertion without damaging the root. So once it is done, so you can see you can attain as good as any other surgery. And the cage we put around 13 to 15 very regularly. So this is a 14 size cage. You can see it has been placed well anteriorly. So I'll just go through a small video. So you can see here I've just landed. I'm standing on the left side here. So this is the lamina I'm exposing. So lamina and this is the edge of lamina. So this is a lamino-spinous junction. So I will give a small cortical cut at this lamino-spinous junction. So I just decorticate the lamino-spinous junction. That's the lamina. I'm going cranially. So that's the cranial aspect of the L4 lamina. So I just use a monopolar here just to strip the muscle fibers. That's the laminar cranial part. So I just give again a cortical cut there. What does this help? This helps in creating a crevice so that I can use a chisel. And this is a pars. So you can see the pars. So I take a shoot here in the X-ray. Then I just decorticate the pars also. So now I take the chisels. So we have custom-made chisels. So now the entire bone, the lamina, a part of lamina, and the pars and the entire descending facet will be removed as one block. So just 2 minutes. So we just remove, we just give a cut here. So that's a laminar cut. So my assistant is helping me to. So that's a lamina pars junction, and this is pars. So you can see the pars. I'm just giving a cut here. Once you can take a C-arm shoot here, can avoid the depth also. So can just, once you give a cut, 2/3, you just rotate the chisel, it will just open up. So once you go deep, it just opens up. The beauty of is the vision. You can have a very good vision here because it's monoportal technique. That's it. So that's a epidural area. You see the epidural vessels. So just coagulate those vessels. Then lift off the entire bone. I'm just lifting off the bone here. That's away from the canal. I just lifted off the bone and remove the entire bone as one piece. Now coming to the joint here, inferiorly, that's a facet, in descending facet joint. I just release the adhesions all around and lift the entire bone as one piece. So this bone comes out as one piece. Just remove that. Hold with a heavy forceps and remove it as one piece. So I can just hold it with a tooth forceps and come out as one piece. So then you work on the disc and put the cage as it. So just hold this important is the removing this bone part. So you can just hold this. Now it is floating. The entire bone will come out one piece. So you can see the bone. I'm just removing from the. So this is as big bone as possible. So more than 3 centimeters. Then I prepare the disc here. You can see I'm just using a chisel to open up the disc space. I use a common regular open instruments. Remove the end plate cartilage under vision and remove it. Now you can see a very good end plates and put a graft. What you can see the graft there, as good as open surgery. We pack the graft. Then I use dilators through the screw port. So just to dilate the tract, I just dilate the tract here. Once I dilate, so that placement of cage is easy. I have dilated the muscles. That's the root, the thecal sac seen. Now my assistant holds this dissector and I put the cage, and we can just bang it in, and as it goes as anteriorly as possible. So this is not biportal. Only when inserting the cage we are using the port which we use for the screw placement. That same port we are using. So definitely the cage has gone as anterior as possible, and you get the best result. So we have done more than 100 till now, and I'll just go through this. Complications, we had one cage back out. It was aseptic inflammation. It came as negative. We went through the same incision again and retrieved the cage easily. We had two infections. These infections were surgical site infections and one epidural hematoma. So these are few examples. You can see grade 1 and 2 listhesis can be done very easily. All the degen discs. The advantage of posterior approach is you can very well decompress the canal also. So decompress the canal and place the cage as anterior as possible. So again, you can use expandable cages also. It's more easy. If you want, you can use it. And more than grade 2 listhesis also been doing now easily, which is easy to do. And 2 level and 3 level can also be done easily. You get very good graft and you can easily do it. So definitely there is a limitation. As I was telling in the morning, learning curve is there, which is difficult. Cost of the initial setup and recurring cost. This is coming down because of the involvement of local companies. And again, training is very skewed in Indian setup. So we need to have a very good training modules, or rather uniform modules, which eSpine Academy follows. So I do agree with this approach. We need to have a very good structured training program. Definitely there is a bright future for spine endoscope, and coming years more and more advancements, more and more people embrace endoscopy. Thank you.
Thank you so much, Dr. Sukumar. That pretty much brings us to the end of the scientific sessions of the last 3.5 days. Dr. Arvind Bhatija has a question.
Yeah, it's because you are going ipsilaterally, you can go over the top and do excellent bilateral decompression. That's what I was telling. If you go transcambian, you can't do a opposite recess decompression. With this technique, posterior technique, you can do ipsilateral as well as bilateral technique very easily, because you just go over the top. And if you want more graft, you can do opposite facetectomy also. Thank you.
That brings us to the end of the scientific session. We have the valedictory function here. We had a lucky draw, which involved everybody being given a form and being asked to visit all the stalls and get a sign from them. We actually had only 5 people who managed most of it. So, Dr. Manas, could you please pick one of these for the winner of the lucky draw? 6.
Dr. Subham Ranjan from Stanley Medical College, Chennai.
If he's not here, then.
Only one.
Only one. We also have the winners of the best poster and the best paper presentations. for the best poster presentations.
Okay, today for oral poster, Dr. Vishnuvardhan for speaking on spinal imaging and diagnostic dilemma case report. Is there?
Second was Vishal Paul.
And the second winner, runners-up goes to Dr. Vishal Paul. Okay. We'll send it to them. And for the award papers, the first prize goes to Dr. Jagdish T for presenting on comparison between microcurve and wire-reinforced endotracheal tube on post-op complications in anterior in ACDF fusion. Is there? Not. Okay. And the second prize goes to Dr. Partha Sarathi, R. Can you introduce yourself? Of which hospital?
I am Dr. Partha Sarathi, Senior Resident Neurosurgery from All India Institute of Medical Sciences, Bhubaneswar.
So, congrats. The certificate and the check will reach you. We'll take a photograph.
Yes, sir.
Names and numbers. Is there printed? So this is original one. Take another one. Now you can zoom.
Thank you, sir. Thank you, sir.
Can I invite onto stage Dr. Selvan, please?
So my job was to be the president for this year, and today is the last day of my presidency of NSSA, and I'm happy to hand over to Dr. Selvan and from Coimbatore, and I'll hand over, and then he'll give a speech and for what he will do in the next year. Want to talk now? Okay.
Thank you, Dr. Manas and Dr. Savitha. I must first appreciate their stubbornness about the scientific program. It was conducted according to the theme and according to the time. They are really stubborn, and it should be followed. It's almost taken up as guidelines. And number two, the beautiful way in which they have organized. 1 year ago, when we were discussing about unreachable manas, whatever we want to tell, we cannot reach manas immediately. So people told me, close friends of him told me to call him around 5 o'clock, which is a late night for me. It's not an early morning for me. So one assurance his friends, I don't want to disclose his friends, his close friends, they gave me, he can do it just like that. He has a big team. So that is what he has proved here. And we are so appreciating, we must appreciate his leadership quality, by which he commands everything and everything is done in the best way, putting us in a corner to make a near matching conference next year. And I invite you all, as a friendly gesture, I invite you all to Coimbatore with your family. But we have a lot of places to see with your family. So we have spared the Sunday. We finished the session by Saturday afternoon. We have spared the Sunday one full day and another half day. You can very well engage yourself in tour activities also. So thank you very much. And I must have a photograph with Manas and Savitr, which was eluding me for the past 2 days. So with your permission, let me have a snap with the organizing team.
The incoming president of NSSA. Unlike other societies having a garden, we have a beautiful way of transferring the presidency, and so that we can wear it for the next year. Like this.
And the reciprocation is done immediately. He becomes the past president.
It's the I'd like Professor Shastri to say a couple of words as President of BAS towards the end of this meeting.
I think at the outset I would like to congratulate Manas and his team for conducting such a lovely 4-day scientific feast. There are certain shortcomings. Most importantly, very little time is left for discussions. So I think you have to tailor your meetings or timing of each speaker in such a way that at least 2 or 3 questions are asked and some amount of discussion is there after every lecture, especially some important lectures. So I think if that is also taken into consideration by the next president, I think the meeting will have much more this thing. Otherwise, the whole spine is covered, tumors, discs, fixations, endoscopy, everything. And I think I would like to congratulate all the speakers. And time management was excellent, and that credit goes to Savit and his team. And the audio visuals were very good, but occasionally that's acceptable. Otherwise, I think overall, I think it was and I enjoyed every minute I was here in these auditoriums, here and in the hotel. Thank you very much.
I know I had the opportunity to give one vote of thanks a couple of days ago, but this brings us to the end of this conference. There's a sizable part of me that's very thankful for today, and not just for the fact that the conference went off well, but I'm thankful that it's done. But this could not have been possible without a huge team which has helped us, supported us, and made sure this ran according to time. Of course, I'd like to thank NSSA for trusting us to run this conference this year, and with your grace and presence, this has gone well. Professor Shastri, as President of BAS, Dr. Manas, of course, have been hugely supportive to make this endeavor run smoothly. My colleagues, my friends, Dr. Raghavendra, Dr. Sai Kalyan, Dr. Kalyan, who's in the OT, and who the entire hands-on workshop is his baby. He has run it from day one, from deciding what the topics were going to be, to getting each and every model, to making sure that they're there, making sure that the sets are available for all the workshops. The faculty for the workshops, Dr. Ravi Suman, my friend, mentor, colleague, all of the, Dr. Venugopal, Dr. Sumit has left, I think, but for pretty much all of the faculty for the workshop, thank you so much for being here, taking time off on a Sunday, and teaching our delegates how to do these procedures. I actually missed thanking Dr. Bhaskar Rao the last time, so if there's a recording that's going to go to him, I thank Dr. Bhaskar Rao for setting up KIMS and for giving us the freedom to run this conference. No conference is possible without the support of our sponsors, and this is all of them. I'd like to read them out one by one, and this is in no particular order. If you're in the room, please stand up so we can give you a round of applause. Larenon, Zuventus, Vasu, Sun Pharma, who managed to get people in and out of Marigold to the hotel park despite what the weather was yesterday. Medtronic, Mudhu Krishna is there. Thank you. Intas Pharma. A huge round of applause, please. Esculap and Bebron. Icon Mesma. Jesco. Intas, the Terrifrac division in Ara. Torrent Pharma, if you haven't collected your certificates yet, please do so outside. Gladstone, Globus, Bet Medical, Jayon, Glaxis Pharmaceuticals, Jishan Biomedical Limited, Brain Lab, Johnson & Johnson, Surgiware, Bion Therapeutics, HRS Navigation, DSS Imaging, GE Healthcare, Electa, Lakshmi Neurospine Technologies, Boston Scientific, Stryker, Reddy Labs, AVM Healthcare, Tosh Pro Medicals, Osteopore, Revo Spine, Desai Surgicals, Mactronics, First Choice Surgicals, and AVD Surgical. We thank you from the bottom of our heart for making this conference a huge success. Again, I thank all of our faculties, all of the delegates who've taken time out of their lives to come here. We hope this has been an enriching conference, that we've sent you back with something new that you'd like to try out, something new that you've learned, and something that will help our patients. These conferences are a labor of love, and if I have to be brutally honest, extremely stressful, but I'm glad it's done, and I thank you all for being here and helping us make sure this is a great success. I also apologize for any problems that may have happened. They were not intentional, and the rains were not my fault. Thank you. Yes, can we have everybody up on the stage for a group photograph?